Yeah.
Warm welcome. Welcome everyone to our re-irradiation symposium. It's a pleasure welcoming you here in Zurich at the University Hospital to a symposium about re-irradiation. Some of you might only have arrived right now for this symposium, but there was some event being held up before. We were having a farewell lecture to a dear colleague of us who was active in the field of hypothermia. And so we tried to establish some connection between hypothermia, which has been used in re-irradiation, and here we are. But obviously, this is not only the only reason why we have decided to have a re-irradiation symposium. Let me ask everyone here in the room, and maybe also to our audience online. We have about 100 participants online. Who has treated a re-irradiation case in the last week? One, at minimum one. Last week, please raise your hand. So it's about half, even more. So that's something which we experience. We are having much more patients we are treating in a re-irradiation scenario. Patients are living longer. They have more effective systemic therapy. They are actually coming into the condition and opportunity, one might say, where local radiation fails. And then it's up to us as a discipline together with our interdisciplinary colleagues to decide whether re-irradiation might be safe and a benefit for the patient. So with that, I would like to hand over to Nikolaus, who has been organizing this symposium, who's also leading a European initiative together with colleagues from ESTRO and ERTC in this field. Thank you very much for coming. I'm looking for an interactive afternoon, so please make it interactive. It's not on us, it's on every one of us in the room, and looking forward to a good scientific exchange. And thank you very much, Niki, for organizing.
Excellent. Thank you very much, Matthias, for this introduction and also for setting the stage for the meeting today. Thank you very much for joining here in person. I think that's really important that we have this close interaction again in person. Warm welcome also to the online community. Matthias said we are around 100, but I would expect that this number maybe is raising even. So there's quite some interest. And we called it Still Navigating Uncharted Waters. So we've been doing re-irradiation for quite a while, but is the evidence really growing and are we really improving? I think we will learn a lot about this afternoon. If you just do a quick search in the internet and just look what has been published on re-irradiation, we see really a huge surge over the past couple of years. But if you look at the red bars, these are all retrospective studies, and the blue bars are the prospective studies. So there are quite some landmark studies published just recently, and hopefully we'll hear about it this afternoon. But still, I think that's not enough. So I think there is interest. We saw half of you have treated re-irradiation patients in the last week, but I think we need to improve on the prospective and evidence generation. Having said this, some of the knowledge that has been gathered, partly on an expert level, but also partly on the experience from the retrospective studies and some prospective studies, have really channeled into these, I would also call it pivotal consensus publication, and that's really an important foundation, and those will hopefully also steer the field and guide the field, but they are very specific to the certain subsites. So I hope that this slide will get more and more busy over the years. And Matthias just mentioned the initiative we are driving with ERTC and ESTRO within the E2Radiate platform. You all know this platform is a prospective observational basket platform for pragmatic trials. It's very successful already with the outstanding OligoCare project. And we just added another cohort over the past 2 years, the ReCare cohort on re-irradiation. And hopefully, if everything works out, we can go live in July this year. And of course, we solicit participation. Currently, we're in the first wave of initiating centers, and hopefully we're gathering more and more centers and more participation also in this cohort. I would also like to mention an outstanding initiative from the astrophysics group, the workshops that have been started, and especially here the re-irradiation workshop, and that was kind of the kickoff meeting last year in Wiesbaden. And I was happy to be invited there from the organizers, from Iliana and from Anne. It's an outstanding group, and this group will really tackle the technological and technical issues we have and we are all facing. So it's nice what we're doing, but I think on the technical level, we need to know what we're doing, and hopefully this group will help us over the next months and years, and there's a huge activity ongoing there. And for this, we really felt it would be important to have a re-irradiation symposium. We are very much involved on a local level, on a national, on an international level. There are many initiatives, and somehow I feel this could be like a small spark, like a small kick-off to really move everything forward before VCARE starts, before the ASTRO initiative. So that's really nice. And you see that we try to cover all aspects. Of course, it's not exhaustive. We could have talked for days, but I think it's a nice selection. We separated it in sessions, and I'm also very grateful to the chairs that they are all accepted, and they will guide the speakers through the session. We have assigned 20 minutes for all speakers, so we hope for 50 minutes talk, and then some couple of questions we can cover, but still we have the break where we can cover more questions and individual questions. For the Swiss colleagues, there's the possibility to get it accredited, and please send an email to this email address, and then we can hand out the accreditation points. And last but not least, hopefully, no, it's not showing up, so we need it in the next slide. Of course, such an symposium is only possible if we have the respective support by the industries, but also by local funding bodies. So here I'm very grateful for the Krebsliga that we got support. I'm very grateful for the companies, and we will display the company slide later on. So again, thank you very much for your kind support. And I already mentioned it. This symposium is also endorsed by SASVO, DEGRO, and ESTRO. So many thanks also to our societies. And with this, I would like to hand over to the first chairs, to Professor Ludwig Plaswil and to Professor Frank Zimmermann to guide through the first session. And oh, thank you.
Okay. It works. Good afternoon and welcome to session 1, Biology and Technology. The first speaker should be Professor Klaus Belker from Munich. Unfortunately, yesterday in the late afternoon or early evening, he mentioned that he got sick and cannot make it to the meeting today. But fortunately, there's somebody else who took over. Professor Nikolaus Andratschke started yesterday in the late afternoon, early evening, to prepare the topic how to integrate tumor and radiobiology into the decision-making process regarding re-irradiation. Now we're happy that you will share your views on this topic with such a short notice. Thanks a lot.
Thank you, Ludwig, for this kind introduction. And of course, my talk will give a lot of a clinician's view, although like more than 20 years ago, I have a slight radiobiology background, which does certainly not compare to Klaus Belker's radiobiology background. But maybe very quickly, if we think about re-irradiation, we will face different clinical scenarios. And I just took the thorax as a prime example. So we may have a situation where we have a full overlap. So it's an in-field, what we would maybe call right now type 1 re-irradiation. We have a situation where the volumes are close by, but not overlaying, but maybe we have critical structures like the proximal bronchial tree that gets a significant dose from the overlap. We would call that right now type 2 re-irradiation. But we also have other forms of repetitive re-irradiation, where we have in the same organ scattered around lesions we might sequentially treat. And the knowledge is increasing, but still we don't know what this low dose overlap might cause. And in the end, we might do it that frequently that also some critical volume parameters we would, for example, here consider for the lung may be exceeded. So these are clinical scenarios we need to look at. But on the other hand, that's just technical considerations. But we need to also look at the clinical situation. What if this happens within a certain time interval? So there's the question, is there recovery if it's within 6 months? Was the first irradiation effective at all? So if we consider high-dose re-irradiation, we might be critical, but for a palliative situation, there might still be a place. On the other hand, if it's irrespective of the interval, we need to consider what were the effects of the previous radiotherapy. Was there toxicity? Is there still ongoing toxicity? And we always need to define the oncologic goal. So what do we want to achieve? And still in those situations, a risk-based high-dose re-irradiation might be possible. And then if we look at radiobiology considerations, so here in those two scenarios, with the central area and with the proximal bronchial tree, here the cumulative maximal doses might play the major role. So we are quite obsessed with always looking at the maximum doses. So this might play a role here. But in this scenario, it's rather the lung we would consider a parallel organ doesn't play such a role. But still, this low-dose spread could induce a higher rate of pneumonitis, theoretically, and there the knowledge is lacking, or there's some work that could describe this. So I would like to separate this in tumor biology and looking at the tumor situation itself and at the normal tissue level. And the first question for me would be, what about the efficacy of re-irradiation? And also quickly, very simply address one of, well, I wouldn't call it a myth, but the question, well, if the tumor is recurring, does the second re-irradiation or second radiation does it make sense? Is it effective at all? And for this, and I'm just borrowing one slide, and John, you forgive me if you will talk about this as well. It's really just to show, to make the case. In the palliative situation, this is a re-irradiation trial on painful bone metastasis, 1 times 8 gray versus 5 times 4 gray. And it's not about comparing 1 time versus 5 times, but it's really to show that the efficacy is maintained for pain in the re-irradiation situation. So there's no difference between the first and second re-irradiation. So the efficacy is maintained. So in the palliative setting, it definitely makes sense to consider re-irradiation. Now here, a systematic review on re-irradiation in the thorax for palliative indication, hemoptysis, dyspnea, obstruction, pain. So it's a bucket of symptoms, and 70% of the patients in this systematic review experience symptom relief. So it's effective. And interestingly, all those cases were considered palliative, and responses up to 2 years were observed, and they were related to the dose. So the higher the dose, the longer the duration of response, and also the survival. We need to be careful because that could be biased, because if you give a higher dose, you may have implied the patient has a longer survival. But nevertheless, toxicity was reasonable, but it was maintained also in this palliative context. Now, very simply looking also at the dose response in the context of SBRT re-irradiation, also here looking at local control and toxicity. So in this analysis, the dose response relationship for both events was observed, but most importantly, again, a dose-dependent efficacy was observed with a moderate toxicity. So there is efficacy of doing re-irradiation, and the major question is really about the patient selection and the treatment intent. And just to summarize some of the prospective randomized trials that really compared radiotherapy versus no radiotherapy or intensified together with chemotherapy. What you can see, looking at overall survival and progression-free survival, and also here in red means that the non-reirradiation approach was superior, but on the other hand, difficult to prove an overall survival benefit in most of those studies, but the progression-free survival was significantly improved in the cases when reirradiation was applied. So there's a local efficacy. So local control may matter in the sense of preventing symptoms, maybe preventing the progression, but in those indications, we may rarely alter the overall outcome. But this is something where we should come to if we do that really in a prospective fashion. So very important, we have a local efficacy, especially if the dose given is adequate. And that's an important point. Sometimes if we think about it's not effective, we always need to think, what is efficacy? So if we give in the first place 60 to 70 gray and the tumor did recur, everything below this dose threshold will not be a local curative dose, but it might still confer a local control for a certain amount of time, and this might be relevant for the patient. And we put this also as a statement in our general consensus we recently published, and the basic thing was we shouldn't be too much guided by radiobiology considerations, but mostly should consider what was the response and the benefit to the first radiotherapy. And to me, the most important factor is really the patient selection. And this is taken also from this palliative thoracic reirradiation systematic review. And they looked at factors that predicted overall survival because they observed longer than expected survival. And okay, except those, it was what we would clinically expect, and especially it's the performance status of the patients. So the performance status is something that hunts us for decades. It is mostly currently the most robust parameter to judge prognosis, but it's also the disease extent and the time to recurrence. And this is something we need to factor in when we decide for reirradiation and when we decide for the intent. Is it curative? Is it palliative? Is this local ablative? And this is something that I consider very important. Here are 3 publications on prognostic scores in a reirradiation setting, and we should much more work on this and improve there. And it's an evolving need that we prepare for that, for such prognostic scores. So patient selection is really key, and I would not discard reirradiation just because the first time did not work. So we need to factor much more in there. Now switching to normal tissue tolerance. How should we assess cumulative doses? And we will hear later on much more. So there, let's take aside the AQD2 calculation, but how do we sum up the doses and how do we come up with reasonable constraints for the second irradiation? So the possibility is just to use the same organs at risk constraints, but only allow the remainder of what has been given in the first course that's in accordance with Quantic or whatever. So the cumulative doses do never exceed Quantic, for example. So that's a very safe approach. That's why it's in green. And there's a rather reddish approach, and you see that I'm biased. There's the possibility that you do the same approach as here, but you factor in recovery, you give a dose discount, and you do the same approach. But basically, in this approach, you end up giving higher doses because you assume a recovery, and we'll talk about recovery later on. And the second approach is just to go for a dose summation as it is and read out the numbers that are above the threshold of Quantic and then decide on an individual basis whether or not you accept it or not. But currently, to be fair, there's no consensus on the preferred method. And very important, and Anna, you will allude on that, we have many troubles when we do dose accumulation. So we have the uncertainty of the image registration, and that's only one part. But we also have the problem, if we have at one segment a very nice registration, it might not fit on another area. So how do we sum up doses there? And then the second point is, how do we recalculate the doses? So we have a very nice formula, and then the recommendation, and we did that also, look up in the literature, and then you come up with a huge range of alpha beta values, and nobody knows what to put in there. And then, of course, is there recovery at all? So what are the assumptions in this context? And this we put also in our statement, where we said biologically effective doses should be calculating when doing dose summation, and especially then if there are different fraction sizes applied. And if established dose constraints are not exceeded, we can easily assume that reirradiation is safe. But now and today we are talking about a situation where we are going beyond, and you will certainly learn more about this. Very quickly about recovery. This is a slide, this is the original slide from Kian Ang on his rhesus monkey preclinical study, and this really, together with Bert van der Vogel and all the and William McBride, set the stage on there is recovery, but recovery has first and foremost described in spinal cord, and sometimes even in a way where you could almost assume 100% recovery. And this has been translated clinically by Carsten Nieder in a palliative setting of reirradiation, where he collected all the data that had been published there and came up with the parameters that were shown, had been shown preclinically. It's the interval, it's the dose first given, and it's the cumulative dose, and there you can calculate the score. So there's significant recovery, and now we also have studies on SBRT and spinal cord and on the brain itself. So there we can make safe assumptions. But if we now go into other organs, it's not that clear. I put it here, the tissue, I put here the recovery with yes and no, and the evidence is based on the preclinical data. We almost have no clinical data except for the CNS and the spinal cord, and here we have the respective publications. And everything in green means there's recovery, everything in red means there's not recovery. There's the opposite. In those cases, we even have a reduced tolerance. So the point is, if we now assume recovery, we need to be careful, because we only have currently one organ where really recovery has been shown, and preclinically, with the other organs, we rather have a decreased tolerance. And we put that as well. So tissue-dependent recovery or dose discount are really subject to ongoing research, and we could not make a clear recommendation to use it except for the CNS. But we should not only be obsessed about the dose. Here, just took the example of the carotid blowout. And the important thing is, of course, the dose is important. But one other thing is also important. If you look here, patient and tumor-related factors. And here we have the situation of carotid invasion or circumferential infiltration. So the risk is low if those factors, those clinical factors are not present, almost irrespective of dose. So we need to consider those factors as well. Or here, another very nice studies from colleagues here about palliative reirradiation to the spine. They observed vertebral compression fractures and myelopathies, but most importantly, in multivariate analysis, one significant factor, so consider 220 patients and only a couple of side effects, but significantly associated with diabetes. So these are things we need to consider as well. So maybe this increases the risk, and we should factor in this as well for our decision making. So I think I've given you a quite good overview of my thoughts, but I may have left you with more questions. And this is my final slides on how to balance the decision making. You see a lot of clinical factors here, and this has to be done in individual decision shared making with the patient. Thank you very much for your patience and attendance.
Thanks a lot for this excellent talk. Other questions or remarks?
I have a question. You mentioned these three models. One would be the tolerance dose acceptance, the other would be to be very aggressive, and then the intermediate one. I think we will involve the individual patient about the decision. And is your strategy more to go to the aggressive part, which means TD55 is not an option anymore, but you accept the risk of 20–30%? Because I think in many cases, this is the final option.
Frank, you're completely right. So the way I phrased it is really something we discuss in our planning clinics, but we should more and more incorporate this, and we're discussing this in our department to create like risk acceptance curves for the patients and discuss this individually and really show the patient what kind of risk are you accepting, for what benefit. And we might see that patients say, I'm not willing to take this risk, so the risk should be very low, and rather I accept a local failure, or the other way around. So this has to be factored in while we are planning. But in general, we are adhering to the second method to really accumulate the doses as they are, then see what's the risk and discuss with the patient, and the patient then decides together with us.
And how aggressive is your policy towards medical oncology? Because I think they offer third, fourth line therapies like that. And do you intervene and say, okay, we should start earlier with re-irradiation now?
Well, in this context, I would consider us rather lucky, because it's the other way around that we get asked to do re-irradiation or repeat organ irradiation in the context where the current systemic line is effective. There are certainly cases where there are discussions, and also where we then retreat because we think the risk is too high and there's another chance of response by an effective treatment. But fortunately, we are currently getting asked, and we're more than happy to consider this and to approach it this way.
Because I think my message would also be go to the medical oncologist and be active really at the front. We have some data and it's reasonable.
Okay, thanks. I think it's really important what you both mentioned, that besides the integration of tumor and radiobiology, the integration of the patient view is really crucial to come to the real best decision regarding each individual patient and his or her situation. Thanks a lot. And again, it was a great talk. And then
now we come to the next speaker, Anne Appelt. She made it after she was stuck a bit in a train station somewhere in South Denmark. Great that you are with us.
Thank you.
She's a physicist, but on her website, she's reporting about being a clinical cancer researcher with a theoretical physical background, but being very active in clinical research. And this is a topic, I think now, as Nika and Rajko already mentioned, we have their biology clinics. Now we come to physics and clinics. So it's great to have you here with us.
Thank you so much. Oh, this one. Excellent. Okay, let's check. How does this work? Yeah. Let's see if this works. It does. Excellent. Thank you so much to the organisers for inviting me today. I am very, very excited about this afternoon and about this topic, of which there is a lot to talk about. So I do actually appreciate Professor Andreas potentially giving me a couple of extra minutes, because it's such a huge issue. Like, how do we deal with the technical aspects of re-irradiation? And I was particularly asked to talk about how to safely assess cumulative doses. But before we get started on this, I just want to put up my disclosures, because as you will see as we go along, we are doing quite a lot of work with research, specifically with their research and development teams with whom we're working on technical solutions for re-irradiation. Okay, so with that out of the way, let's think about the situations that we have. And Professor Andreas has very nicely outlined some of these challenges. So this is just an example in the lung. Patient who previously received treatment for a locally advanced non-small cell lung cancer, and they come back years and months later with either recurrence or a new cancer close to that previous treatment target. And that's where we start considering what will be the cumulative doses to organs at risk. Is this safe? What can we actually deliver in this setting? And so we end up thinking about things like, how do we evaluate the combined treatments? Where did we previously radiate? How much overlap are we going to have? And so on. But also, how do we actually plan this new treatment plan? Can we take the previous dose into account when we optimize this plan, not just in which constraints we're using, but spatially, where did we radiate before? And on this larger level, and not just for the individual patients, we want to think about getting this information about cumulative doses to be able to relate it to outcomes so that we can establish safe cumulative dose limits, which is something, as we've heard, that we severely need. And again, as was highlighted before, in our recent EORTC ESPO consensus that was published last year, we clearly state the full information on previous treatments, imaging, treatment plans, etc., should be considered when you plan a re-radiation case. So you need to understand the spatial information about the previous treatment. But furthermore, again, as we said before, we also state that you really should calculate some level of equi-effective doses. So in other words, when we are considering cumulative doses for re-radiation, we need to consider the spatial and anatomical information, but we also need to consider the radiobiology when we're assessing the combined treatments. And so let's start from an end. Let's start with the spatial information. And so everybody who's doing re-radiation cases will know about the often considerable anatomical changes that we see between treatment courses. For the example from before, you can see changes in breathing pattern, you can see changes in body habitus, and so on. But actually, this is a relatively mild case of anatomical changes. If we go into the pelvis, we see things like change in positioning, prone versus supine. We see changes in whether they've had surgery or not, so disappearing tissue, changes in organ filling, and so on. And even in settings where we would normally consider the anatomy pretty stable, like in the brain, when we're thinking of these longer time intervals, you end up with subtle changes that might actually matter for your dose accumulation. Now, so what we want is to be able to map this original anatomy onto the new anatomy. And the good thing is that we by now actually start having deformable limits registration algorithms that will allow us to do this. And if we can do this, then we can also map the dose using the deformation map from our image registration. And even better, many of the commercially available algorithms are getting better and better. There's by now, I think, something like a dozen papers published. These are just a few key papers which have looked at the use of deformable image registration for dose accumulation for re-radiation. And generally, the general message across all of them is that there is a value in using deformable registration compared to rigid registration, even when there are uncertainties related to the deformable registration. And so we did our own small study in Leeds, where I'm from. We looked at a series of patients who received pelvic re-radiation, so first some normal fractionated radiation and then stereotactic treatments for oligometastatic disease, for nodal recurrences, and so on. A small series of 21 patients, primarily men. And we tried to set up a pathway that will allow us to deal with some of these often dramatic changes that we will see in the pelvis. So this is just one example of the patients who had a lot of changes. This is a simple overlay. And then with our pathway, where we used a combination of commercially available algorithms and RayStation, we were actually able to map these anatomies together. And so obviously this looks convincing. It looks like we're getting it all into place. And if we look at the statistics for the metrics describing our ability to do structure-based matching, we saw that this was indeed very good for structures like the bladder. But for example, for the colon, we saw huge variation in the similarity between the structures and really not very good mapping. And I think what this shows is that we need to consider the quality of our image registration, both on a per patient level, but also on a per organ level. The way we thought it was most efficient to approach this is to use some sort of standardized but qualitative scoring of the registration quality on a per organ level. So in this case, we would look at the bladder and say, this is good enough to use for dose mapping. we would look at the bone and says that's not very good in some parts, but if we go, sorry, see, is there a pointer on this one? No, okay. Well, the top bit, so the cranial aspect of the bone is not matched very well, but the inferior aspect is actually where the new target was, and that's matched quite well there. So we say that is sufficient to use in this case for dose mapping. While for the bowel loops, that's clearly insufficient. It's all over the place. And instead, we will be using some simple summary measures such as the max dose. And so this is the approach that we've been using, that we've been assessing the image registration quality on a per patient level. Now that generally works quite well, and as I said, modern algorithms do seem to perform quite well even in these challenging cases. However, it's worth being aware that there are a number of issues with algorithms that have been developed not for the re-irradiation setting. We just need to keep in mind when we're using them. So one of them might be that these algorithms are inherently constrained so that deformations are continuous. While when we have large anatomical changes, we often have sliding interfaces and missing tissues, which are not actually allowed by the algorithms. Another thing is that most algorithms rely on image intensity to drive registrations. So it's an assumption that the intensity of the same tissue stays constant. While if we have treatment-related changes, the tissue intensity might have changed on the images, which means that assumption is broken as well. And then finally, the big one, which I think we need to keep in mind, is that our registration attention is driven solely by image information, potentially with some additional information from segmentation on the images. And that is generally good enough in the in our standards use of radiotherapy, where what we need to check is that is this image matched across the whole image. However, if we look at, so this is a map of the geometric uncertainty of an image registration. So it's hotter, there is more uncertainty in the image registration. And here's the corresponding dose distribution for this patient. And what's interesting is now if we combine those two and then calculate the dose mapping uncertainty, what we are getting is actually that an area with high geometric uncertainty might have very limited dose mapping uncertainty, because the dose in that area is homogeneously low, while another area with low geometric uncertainty might have very high dose mapping uncertainty because it's right on the dose gradients. So dose distribution gradients matter when we use these registration algorithms, and they don't currently take that into account and use that sort of as a weighting factor to where you should drive the precision of the registration. And that's something that really ought to be prioritized in further development. Okay, but assuming we can get a decent registration done, sorry, before we go for that, just if you are interested, that paper that I put up there is a very recent publication with a very nice overview by Martina Moore and Eliana Vasquez-Osorio on the state of image registration to use for dose mapping, including re-irradiation, and I can really recommend it. Okay, so where I was getting to, so assuming we can get our image registration right, we can then map our original dose onto our new scan. And so now we want to try and actually be able to sum our dose distributions. And we now get into the issues with radiobiological effects, such as fraction size effects, as was alluded to in the previous talk. And the issue here is obviously that irrespectively of which dose and fractionation regimen we use, and whether they were the same or not, or too great a fraction or not, the individual voxel dose in our organs at risk is going to be highly heterogeneous, and the dose per fraction is going to differ across all of our voxels, which means that we need to do voxel by voxel corrections before we calculate some dose and before we extract any cumulative dose statistics, irrespective of which dose and fractionation scheme that you use. So you need to first do a full dose distribution recalculate EQD2 rescaling for each of the two treatments, and then do a combined dose distribution. And the noise, and this is what it looks like on our sort of summary slide from before. You end up with a dose summed either EQD2 or a BED or something like that. Now, the nice news here, the good news here is it's not technically challenging. It's a straightforward rescaling of dose metrics with some minor technical pitfalls to consider. And the main issue is really remain non-technical, so not the topic of my talk. I will leave that to all the radiobiologists and clinicians. And even better, quite a few commercial software systems now have this available, for example, RayStation and MIM and so on. Good. So we're actually now in a situation so we evaluate combined treatments. And for this cohort of patients that I talked about before, we then did that. We compared various strategies. And what we found, just as sort of the summary results, was a substantial number of the patients had changes in the assessed organ of risk dose when we introduced the formal limits registration and EQD2 dose calculation. So it's just to say that we, in line with what's out there in the literature, definitely found that these approaches matter for combined dose evaluation. However, we also know that that is not necessarily what people do clinically. Even though there is a recommendation to do this, people use all sorts of methods, from rigid registration of physical dose transfer down by isodose lines transfer and some simple sort of point dose estimates, going from more complex to less complex. And so we wondered, what does this actually mean for the variation? How varied do people assess doses? What does it mean for your assessment of cumulative dose metrics? So we got hold of 24 institutions as part of the workshop we ran last year. We sent them 2 cases, 2 revalidation cases each, a head and neck case and a lung case, all of the DICOM files and so on. And we presented this work. If you're interested at ESTRO this year, if you have access to the presentations, but we're also in the process of writing it up for publications. We asked the centers to follow their local institutional protocol for assessment of re-radiation cases, whatever software they had available, and then report various cumulative dose metrics to us. And optionally, they could provide a full map dose distribution to us without doing the extraction of dose metric, just mapping the dose distribution and sending it to us. And so what we found was rather depressing. We found for most of the dose metrics that we were concerned about, particularly high dose metrics and max dose metrics, we saw plus minus 20 gray in the assessed across the institutions in their assessment. This is a lot. I mean, this is the sort of thing that will determine whether this patient is getting offered a potentially curative treatment or not. Really depressing. And it didn't really change if we look at the EQD2 doses. We gave them alpha beta values, by the way, so that's not the cause of the variation. Just still depressing. Slightly better, when we just asked them to map the dose and not do anything more, it actually got quite a bit better. So it looks like it's not in the dose mapping part it goes wrong, it's somewhere else, and we're still sort of exploring that. So at least the image registration is not the issue here, and that's good news. They used all sorts of different systems. So, I mean, that's sort of where we are with the evaluating combined doses. But actually, as I said before, what we really want is to take that one step back and instead think about how we optimize plans. So once we have the map dose, rather than wait to evaluate things until we have a new treatment plan created, we want to try and think about how we optimize the new plan, taking the previous dose into account. And what we'd really like to do is do a spatial optimization, so use the full 3D information from the previous treatment. Here we hit a bit of a snag, because plans are delivered in physical dose, and our cumulative dose constraints for organs with risk radiation is only really well defined in EQD2 or BED and so on. So the plan optimization and the continuous evaluation of our objective functions must happen in EQD2 while optimizing a dose to be delivered in the physical space. And that's just not how our normal optimization modules in our treatment planning systems work. But we've been working on this, and this is where our work with RayStation comes in, because we've been working at implementing this step in RayStation. And I don't want to talk about this too much in detail, partly because it's something that's not yet available clinically. But to briefly show you what this looks like, we've here got our map dose, mapped from the previous, in this case, a rectal cancer plan, onto the new scan. We then set our target objectives for our new treatment target as we would normally in physical dose. Then we set our organs at risk objectives to work on the combined dose distributions in EQD2. And we are able to set organ and even optimization function-specific alpha, betas, and recovery factors. And we end up with a new plan that's optimized and ready to deliver as it is, but which has taken the previous dose into account. And so just again, to go back to our series of 21 patients that you saw before, I was treated with pelvic saber radiation. We compared a very manual standard clinical planning approach to our background dose optimization approach. What we found was that we were generally able to lower the organ of risk doses and to increase the PTV doses, not massively, but enough that it was clinically meaningful. But even more importantly, I think that the feedback from our treatment planners was that these were so much easier to plan because you were not doing the continuous, oh, what's the point dose there, what's the point dose there, combining them, going back to the clinicians to ask whether this was acceptable, and laborious, manual, and often error-prone process. So we think this really has promise as an approach to plan re-irradiation. We've also worked on other treatment sites than just the pelvis. This is just an example from the for thoracic, so a lung re-irradiation where we looked at 6 cases. And we got a much higher proportion of clinically acceptable plans using the background dose optimization approach than the manual plans. And they were clearly also, for most cases, the background dose optimization approach was clinically preferable in a blinded evaluation by our consultant oncologists. So if we can do all of that, we're still left with the issue of getting cumulative doses related to outcomes. And I don't want to talk too much about this in the interest of time, but what we would hope to do is that if we've got improved evaluation of cumulative doses, then we would get a better data for modeling of normal tissue toxicity, would allow us better estimates of safe cumulative doses. And there are a number of retrospective patient series out there that's already tried to do this. This is just where I then want to put up sort of a word of warning, because from this work I showed on the multi-center evaluation, there is a lot of variation. And if you imagine, a plus minus 20% variation in your estimated dose to the bronchi or similar, and you're trying to use that data to then model the risk of toxicity, you are going to fail. So I think for multi-center studies, you really need to consider either to clearly describe a methodology for determining cumulative doses, or to do this centrally, as where we showed much better consistency, as I talked about before. However, even if you are doing all of this, even if you're having consistent methodology, even if you're doing things centrally, there will still be some unavoidable uncertainty from your image registration and from your lack of biological knowledge. And so you need to consider how you're taking this into account, especially for individual patients assessing their treatment, planning their treatment. And this is very much work in progress. So this is what we're working on right now. We're looking at how we can incorporate that into our map dose, this level of uncertainty. We're looking at things like taking the individual voxel and then searching the sphere around that voxel for what dose is delivered in some distance from the voxel to give you some sort of robustness in the mapping. And then similarly doing the same with our radiobiological parameters, which gives you some sort of resample map dose that incorporates uncertainty, which you can then use to evaluate combined doses and to optimize re-radiation treatment plans. To do all of this, you really need optimized clinical tools. And I think this is one of the big challenges that we have right now, is that we just don't have all of the tools available that we would like in the clinic. So very recently, we put out the commentary in the Green Journal, which called a call to arms, both for physicists, but also for radiation oncology vendors to get us those better tools to be able to deliver safe re-radiation. And so that brings me to my end of my talk. I just want to acknowledge the very big team in Leeds who are working on re-radiation. I have a lot of excellent colleagues, not least Dr. Louise Murray, who is our clinical lead on re-radiation. And then for sort of the final slide to leave up there is a slide on the Astrophysics Working Group on re-irradiation that Professor Andrassy very kindly mentioned, which was established last year in Lisbon as part of the physics workshop. We've been continuing the work, most recently met up at ASTRO. If you're interested in getting involved, please do get in touch. And we've also just now set up a re-irradiation mailing list, which is for sort of more general and probably infrequent updates on re-irradiation. So please also sign up for that if you're interested. Thank you so much.
Thank you, Anna Appelt, Associate Professor, St. James's in University Hospital Leeds. Thanks a lot. You mentioned plenty of prerequisites for treatment planning for re-irradiation. I do not talk about suffering, just receiving a few PDFs of former treatments,
Yes.
5 or 10 years old. So, but how do you manage with adaptive radiation therapies a sequence of replanning? Is this also a plan? Because then you have really, you mentioned explanations in the pelvic area where you have a mobility of.
So that's a really good question. And I should say, actually, as part of this Astrophysics Working Group, we have one subgroup that's working on recommendations for best practice for dose accumulation. And the adaptive question has come up because nobody knows. What we do know is that if you have multiple plans, you optimally need to consider each plan almost as an individual treatment course and recalculate, do the mapping between them, recalculate to EQD2, and then deal with them like that. Which what you want to do, but is very, very resource intensive. So one of the things we're trying as a working group is sort of coming up with a minimum requirements, what you get away with, either if you don't have the resources, or you end up with a few PDFs, as you're saying. Like, what do you do if you don't have 3D information? You just have your PDFs. What's the safe minimum requirements? And so I can't really give you a good answer right now, but just to say that there's something we're very intensely working on.
You have been very skeptic about your evaluation with the broad variety of individual estimations.
Yeah.
When we started with contouring clinical target volumes, we had the same, and now we are more or less mainstream.
Yeah, so I think we can improve. I think we can improve it a lot. I think we're in a very, very early stage, and everybody's sort of inventing the wheel themselves or using whatever they think is appropriate, and we need good guidelines.
Yeah, thank you. Questions from the auditory? Nikki, you have a question? No, just
no. I don't have a question. I have a present for you.
Thank you.
Thank you very much. The Swiss Top 10, excellent for coming and for this excellent presentation.
Thank you so much.
And good luck with your journey home.
Thank you.
Better than coming here. Now we're coming to the next speaker, and if you think it's just Zurich again, it's not Zurich again, because Madeleine Chamberlain made her education as here now senior dosimetrist, but far away abroad in New Zealand. So it's really an international meeting. And now she will give us maybe also some practical advice with her experience working with the MRI Linac, how to fuse the physics, techniques, biology aspects into a clinical treatment. Thank you.
Thank you very much. Okay, so these are my disclosures here. Thank you very much for the invitation to speak today. I'm very happy to represent as a radiation therapist and dosimetrist here from Zurich. So I'm going to step back, zoom out a little bit from what Anna was talking about, and really look at the workflow as an overall, and what do we have right now at the tips of our fingers that we can implement into the clinic today. So where are we currently at? There's really a lot of interest, a lot of hype, a lot of discussion about re-irradiation in the community, and a real need from clinicians for tools to be able to deliver this for their patients. But we also have a lot of challenges and even more open questions. So how do we balance the unknown with the need for a solution right now? So we've already heard a couple times today about the consensus statement on reirradiation, but I'm going to bring it up again because not only is this very important, but we can use this to define our clinical workflows. So we really now have a common language that we can speak about reirradiation. So in the literature, we are starting to have, as Nikki showed, more and more literature about reirradiation coming up. But when we look at the workflow and these particular technical aspects, we're really at the beginning of this. There's a publication here from the team in Michigan about a special medical physics consult process for reirradiation patients, which involves performing a dose accumulation before the doctor finalizes their target volumes and prescription. And this is something that we've also implemented here. There's also a few publications on different technical solutions and different steps of the workflow, but right now we really have no consensus on the overall reirradiation workflow. However, we have implemented something here in Zurich with the tools that we have available to us right now, because we cannot wait until the perfect solution is available to us. So first of all, the first step is to actually identify our patients that require reirradiation. We need to gather previous treatment records. So this may be going into an archive somewhere and gathering out your paper documents. You may have to find old treatment planning systems and re-import them. Or you may even need to go further afield and ask different clinics or even in different countries for the previous treatment information. And this can be a lot of work. Then we can define the reirradiation type of our patients. And that's something we've implemented here this year, that every patient has a drop down in their prescription on what reirradiation type. And this will instigate the next steps in the workflow. So after that, we then need to perform the reirradiation preparation. So for all type 1 and type 2 reirradiation patients, we will now perform a dose accumulation before the doctor finalizes their target and prescription. So we will accumulate all of the previous plans using a rigid fusion method, and then sum all of the doses physically on the new planning image. Ideally, as Anna said, this would be done with a 3D dose distribution, but what do you do if you don't have this available to you? If you have the information on what was done, you may be able to recreate these plans in your treatment planning system. And this is something we do from time to time. Or you can look at the overall prescription and the maximum dose to particular organs at risk and take this into consideration in your new plan. Then we need to look at defining our target and prescription. The radiation oncologist needs to have a look at that dose accumulation we performed and make sure that the fusions we done are fused in the location that's relevant to this patient and that it makes sense, and takes that information into account when defining not necessarily the target, but the prescription and also the organ at risk priority. Are we allowed to compromise dose to the PTV to maintain our doses to the organs at risk? Or is the PTV coverage a priority? This communication with the planning team is extremely critical to make sure that you have an efficient workflow. Then, if we come to the plan creation itself, I want to show you a very simple technique that anybody who has a treatment planning system with 3D dose calculation can perform. This is something where you don't need a third-party system, and it's not in the research phase. This is something that's published and people are using very commonly. So I have an example down here of a patient that was treated previously for head and neck cancer and then came back for spine metastases. Then we wanted to treat with a synchronized integrated boost concept. However, we had a spinal cord tolerance of 45 gray, but in some parts of the spinal cord, there was already dose received, and in other parts, there was very little dose received. So if you didn't take into consideration the previous treatment, you would need to spare that entire spinal cord through that volume, and you would reduce the coverage to your PTV. However, by taking into account the previous treatment, we could segment different parts of the spinal cord to make a stepwise gradient of our dose distribution along the spinal cord. And in this way, we could increase the coverage of the PTV overall and only spare where is needed. This is really an easy and accessible solution with no need for extra software. So I think it's really important that not only do we talk about what is upcoming, where the research is, but what can people do today to implement in their clinics if they're starting from zero. Then we want to perform also an equivalent 2-grade dose calculation. So we do this for all the type 1 and type 2 reirradiation patients that are being treated with an SRT or SBRT plan with a dose that's greater than 2.2 gray per fraction, as well as having a significant overlap with the previous treatment. So in this case, we had the spine treatment overlapping with the head and neck, so we needed to perform this. How do we do this? We're very, very lucky to have a fully automated workflow now through MIM. So we're able to, within a few minutes, export our plan to MIM. It will automatically calculate the EQD2 for us with our preset selection of alpha beta ratios, and then export it back into Eclipse for us. And then we just need to do the final input. This has significantly increased our efficiency for these types of plans. Some other things you need to take into consideration is if you don't have the option to perform this 3D EQD2 calculation, you can still do this with a point dose. There's plenty of online calculators where you can do this, but also, for example, with Varian, there's some free scripts you can download online to be able to perform this. What alpha beta ratios are we going to use? And are you going to use it for the GTV or not, because you're more concerned about the organ at risk dose? How do we consider tissue repair? And are we performing EQD2 or BED? Because this is also not consistent in the literature. This process allows us to assess potential toxicity to organs at risk relative to 2 gray, which is a language we are also all speaking. So finally, we need to do our physics review and plan approval. Hopefully this will pass. And we asked both the physics team and the doctors team to check again the fusions and dose accumulation. Hopefully we have our plan approved. And then we also make a documentation of any organ at risk doses that may be out of tolerance or outside of our standard workflow, and any decision making that we did along the way. Thorough review of the dose accumulation and EQD2 is critical. As Anna showed, there can be huge differences if you don't look specifically in the area that you're interested in. So now I come to talking about the MR. So we want to have a look at what may be the benefits of MR guidance in the reirradiation setting. We now have the ability to perform daily online plan adaptation. So for patients where there may be changes in the anatomy from day to day, we also have improved image quality. So we're able to localize the patient and we can recontour with a lot of information at the tip of our fingers. And we can perform gated treatment delivery, which allows us to significantly reduce the amount of healthy tissue that we're treating and also the amount of tissue that was previously irradiated. So this is a significant improvement for reirradiation. So I really think this may be the perfect combination for performing reirradiation. If we have a look at what we've done ourselves with our MR Linac, so in the year January 22 to 23, we treated 13 type 1 and type 2 reirradiations. A lot of these are in the pelvis and abdominal area. 3 of them were repeat organ radiations, and we also had, on top of that, 21 repeat irradiations. So we're really utilizing this machine in this context. And we've had this machine now for 4 years, so this is only a small snippet of the patients that we've treated. I wanted to look at one particular case to go through a stepwise of how we treated this on the MR Linac and what we had to think about in this context. This was a 55-year-old male patient who was originally diagnosed with rectal carcinoma. They first had their course of treatment on the Meridian in 2020 for an SBRT liver metastasis, 5 × 7 gray. This is the volume you can see in red. Then their third course of treatment was also for liver metastases on MR-Linac in April 2022. And this is what you can see in blue. And so there's really a geometric overlap of these two volumes, which makes it a type 1 reirradiation. Then there was also contoured in pink here in the middle, a region where there was a high risk of toxicity. So we were given this structure from the radiation oncologist and said, I'm really concerned about this region between the two volumes. I want to give you a specific constraint for this region. So what we did is we created a physics PTV, which is cropped away from this structure. And we delivered our dose to the remaining part of the PTV and really limited that dose to the in-between of these two volumes. What is really critical when you come from creating one reference plan and treating that for the entire course of the treatment to online daily adaptation is you really have to be careful about what's changing from day to day. You have the options for structures to deform on a day-to-day basis or to rigidly copy them over. And in this case, because it's a specific area that we wanted to spare, we made sure to rigidly copy that over every day and check on a day-to-day basis that we were meeting that constraint to ensure that overall we would still maintain this. Then we treated this with a gated treatment delivery. So you can see that when the patient goes into breath hold, our beam will turn on, and at any time that the patient breathes out or they're not within the desired location, the beam will automatically turn off. So this is how we can make sure that we're actually treating in the exact spot that we want to. But we do need to take into account that there's still a lot of open questions and considerations in this space. So as I was saying, how should we handle this online? This is just one option that we're doing right now, but there are plenty of other options that are still to be explored. What help structures are needed? Should we be segmenting the organs at risk? And how do we know that we're still within our planned sum or EQD2 tolerances? This also leads into the dose accumulation question. Should we be accumulating the dose for every fraction? Right now, that would be extremely time consuming. However, I know on the Elekta MR-Linac, there's some research going on there about real-time dose accumulation. And should we accumulate the planned dose or the delivered dose? Because there's some research out there now that's saying the delivered dose is far more indicative of toxicity than the planned dose, which is logical, really. And how should this be managed? Because right now, we would not have the staff or the resources to perform this for every fraction, for every patient. So this is where we also need help from the vendors. So some of these questions are still to be answered. Now, I just want to quickly mention some ongoing work. So as Anna was saying as well, there are groups out there looking at more in-depth optimization solutions for treatment planning of reirradiation patients, where you can use the previous treatment as a base dose plan for the current treatment. And as Anna said, what this group found is that sometimes even just with one optimization, you can achieve a good plan with good dose to your good coverage of your PTV and achieving all of your organ at rest tolerances. And this is something I'd really like to explore also in the MR guided situation. Coming to my take-home messages, I really want to reiterate that the consensus for definition, categorization of reirradiation is available, and we should really be using this for reporting, not only in the literature, but also in-house. We do not have a consensus for the reirradiation workflow. However, this should not prevent us from utilizing the tools that we have currently available to us. And the MR-Linac can provide unparalleled options for reirradiation, but we must further investigate to realize its full benefits. Thank you very much.
Thank you. You mentioned that a very strict guideline was established for the workflow. Did this influence also the timeline in general, so that you take 3 or 4 working days more for this special planning, or is it on the same?
I have to say, in the almost 7 years that I've been working here, we have been performing re-irradiation, and we do manage to fit it in our normal, in our standard treatment time that we would for any patient, unless we don't have the information at our hands to perform what we need to do. So, I mean, as we discussed already in the literature, there's not always guidelines about what organ at risk tolerances we should accept. So sometimes we do have to do some back and forth iterations. So sometimes it is safer to not hand out the patient's new site appointment until you can collaborate together. Yeah.
Any question from the auditory? So,
yes, please. One question from the chat. So the question was, how do you define dose maximum? And I think the question relates, is it a point max, is it volume, is it related to, is it in the tumor and the organ at risk? So maybe you could comment on that.
Yeah, I think this is a really great point. And I think if you asked every clinic that was doing this, they would give you a completely different answer. It's dependent on the physics team, on the doctor, and also the region that you want to look at. And also the organ at risk. Is the organ at risk a serial structure or parallel structure? Are you concerned about the point dose or the volume? So this is a very, very difficult one to answer, but it depends what you're interested in, for sure.
Regarding the workflow, maybe there's one issue to add, which is not technically related. It's about the follow-up of the patient after the first treatment. Mm-hmm. In my opinion, of course, we need written documentation and have the information. For example, did the patient suffer of any side effects after the first treatment, and was it acceptable or unacceptable on a high grade of side effects?
Yeah, this is something that I didn't mention, but it is something that we do talk about in our workflow, especially in the thorax region, because there is discussion about if a lung was treated up to 20 or 30 gray, do we still consider that like viable lung tissue or not when we perform our re-irradiation? Should we actually avoid the areas that we treated previously or avoid the areas that never got irradiation? So there's definitely something to consider there. And I think that patient interaction that was discussed before is very important as well.
Yes, and also at the entrance, this is not your job, but the job of the clinicians. The entrance is typically the tumor board. And I know and have in mind many of those tumor boards where we did not receive any detailed information about pretreatment. So in principle, if you have any doubt, invite the patient into your clinic to evaluate if there is a chance, and not follow the surgeons who said, okay, there was something I've heard, so we go into definite surgery with high risk of side effects. So this is also relevant for us as clinicians, technicians, and physicists.
And maybe a comment, I think that a multidisciplinary team approach within your clinic is so important, because each group bring different questions to the table that I think are really relevant. Okay, thank you.
Excellent. Maddie, thank you very much for this great talk.
Thank you.
For you as well, so the top 10. Thank you again.
Thank you.
And
okay, so good afternoon. Now we are going to open the second session. It is always about technology and radiobiology. So I welcome Professor Camilla Kronborg. She is a senior consultant in Aarhus in the Proton facility. She is involved in re-irradiation studies and in the ASTRO working group on re-irradiation. So she is going to discuss the physical qualities of protons and also the radiobiological uncertainties that are related to proton re-irradiation. Get the hair back.
Thank you. So first of all, thank you for inviting me for this symposium. It's very great to be here. I'm a consultant and associate professor at the Danish Center for Particle Therapy, and my disclosures are that I'm a clinician and I'm working only in proton therapy. So as you'll see, that might be important. Okay, so the topic for this talk was, does the superiority of the physical properties of proton therapy beat the uncertainties in biological knowledge? And my initial thought was, yes, it does, because we know with proton therapy, the interval dose is lower. But of course, it is not as easy as that question. So what do you do if you have a difficult question? You go to AI and ask the ChatGPT the same question. And the answer is, while the physical properties of proton therapy provide potential advantages, biological knowledge should not be overlooked, and there should be a careful evaluation. So not much help there. Okay, so also I used the scale like many of you did. So I tried to list some of the uncertainties, biological and other uncertainties. And on the other side, the physical properties of proton therapy, and it seems like a bit of an uneven match, this. So I took some of these, and the list is definitely not exhaustive, but some of these uncertainties, and tried to group them into 3 categories. One category with patient factors, tumor type factors, the previous radiotherapy, which ultimately comes down to toxicity versus efficacy. And then we have some technical uncertainties that might not be unique to proton therapy, but might be a bit different for proton therapy. And then we have some uncertainties that are mostly related to proton therapy. So when we decide as clinicians for re-irradiation, we have some form of the, is there a pointer here? No, but in the middle, we have some thought about the tumor control probability, the normal tissue complication probability in our heads. But these models that we have are mainly from the primary irradiation situation. We have some models, as was mentioned before, for a spinal cord with high cumulative doses. So we have something that we maybe can rely on. But most often we have a series of toxicity dispersed on a cohort that doesn't guide us that much for the normal tissue complications. And then we also have uncertainties of the dose for the tumor. We have some knowledge, but for many tumors, we do not know about the re-irradiation situation, and we apply the knowledge from the primary irradiation situation. On top of that, we put a lot of different factors into the decision of whether this is a good idea to go for re-irradiation. Is it an adjuvant treatment? Is it a definitive treatment for a patient with no other options? How was the previous treatment given? How was the side effects from the previous treatment? How long ago was it? What was the response on the previous treatment? And also, is it a fit patient? Or is a patient like this that I actually treated with re-irradiation? You can see that he has more heart than he has lungs, and he wasn't suited for surgery or chemotherapy. So all of these decisions go into this very maybe blurry model. They're not that defined in re-irradiation. So just to make examples of what we do in proton therapy, most of our treatments are type 1 irradiation, and they are always some kind of rather high dose. We do not do palliative re-irradiation, or not with a palliative intent anyway. So we have some protocols with re-irradiation. We have a re-irradiation dose escalation protocol for rectal cancer and for anal cancer, both recurrences. And then we have one for head and neck cancer, with the aim of decreasing toxicity. And then we also have for breast cancer that are treated outside of the breast cancer trial at our facility. So looking at the breast cancer cases, here is an obvious gain of the physical properties of proton therapy, because we can give the fields anteriorly and then put the fields parallel to the previous isodose curves. And that is what's seen here. So these patients, they have comparative plans, but it's often not necessary, because we can always, or almost always, cover the target with more dose, with less overlap. So we have quite a few of these patients, but they're treated outside the DBCD or the breast cancer trial at our facility, but it's obvious that we have a better target coverage. Then we have the head and neck cancer trial, and in Denmark, head and neck cancers are also treated with photons, 60 gray, hyperfractionated 1.2 gray, 10 fractions a week, so they have a photon option. So these patients, we make comparative dose plans, and we look at the comparative dose plans at a national conference. And there are no definitive objectives in this protocol. So it's a discussion of pro and cons. What organs at risk do we spare? Like the patient here, it could be the contralateral vessel or a part of the esophagus, but it's discussed on an individual and case basis if there is any gain for proton therapy with the aim of decreasing toxicity. And then we have the pelvic re-irradiation trials for rectal and anal cancers. And what we did pre-trial here is that we made comparative dose escalation plans, comparing patients that were treated with around 40 gray photons. And then we made dose escalation plans to 55 gray and 65 gray. And we saw that we could keep the mean doses low or even still lower than the photon plans. It's also a hyperfractionation trial with dose escalation. These patients often do not have an alternative, or the alternative is palliative chemotherapy. So they are referred directly to proton therapy, not with the aim of decreasing toxicity, but with the aim of increasing efficacy for this patient group, because we think that 40 gray that we normally use is a little bit low for this re-irradiation situation. So these trials have different outcomes, different endpoints, different criteria for going into the trials. Also, when re-irradiation and thinking about toxicity, we have to think about organs at risk that we may not normally take into account. In the pelvic area, it is the nerves, the ureters, it could be bowel circumference, that are all delineated and taken into account and prioritized in the planning situation. It could also be a case with a patient over here who had brachytherapy, where we tried to, I'm not sure it's correct, but delineate parts of the bowel that were subjected to the brachy needles. So we tried to spare these parts of the bowels. And also a patient with one kidney where the ureter was of highest priority for the remaining kidney. In this re-irradiation trial for rectal and anal cancers, we tried to apply some of these constraints that we talked a little bit about before, going to the highest primary or 50% above. But with the dose escalation, we often end in these very high doses for these patients. And even though we have these constraints, it's very individual, and a lot of different factors go into the final decision on which dose to accept. So this was a little bit about toxicity and efficacy. What we think about when using proton therapy. The trials are different. And then we move on to some of the technical uncertainties, which might not be unique to proton therapy, but might be a bit different, as the positioning. This, because we with proton therapy sometimes can treat just from behind or posteriorly. A patient like this who had a retroperitoneal recurrence, we place the patient in the prone position, and you can see that all the organs at risk are pressed towards the target actually. Instead, if we place the patient on the back or in supine position, there's a nice separation of the organs at risk, the duodenum and the pancreas. And with the dose gradient that we have with proton therapy, we can actually spare a part of the organ at risk for a patient like this just by the positioning. Moving on, the imaging is also very important. This is not unique to proton therapy. I just want to stress this, that these patients have received radiotherapy before, they have received surgery before, at least once, and it's very difficult to differentiate between fibrosis, tumor, scar tissue, so do the optimal imaging that you can. And these are just examples of a no contrast CT, a contrast CT, and the sufficient MRI, where you can see down here in the bottom that the large volume that you see here, a large part of it is a cyst, then combined with some surgical material that has altered a little bit, and then there is a recurrence down in the bottom. So it's very important that we do this proper imaging. And also other imaging than what we normally do can be important. This is a late contrast scan, and we use this for visualization of the ureters on the left. This is a normal contrast scan, but if we do a late phase scan, we can see the ureters very clearly. And as they are organs at risk for these patients, we do both scans. So now moving on to the very difficult part of dose planning. As Anne showed us, they have a very nice system, a solution within one system. We do not have that. So we go from Eclipse, we import the previous plans, and we're quite successful in getting the previous 3D dose plans. We do voxel by voxel EQD2 in velocity, and then get them back to Eclipse. And with the re-irradiation plan, we do the same back and forth, and then we combine or sum the doses in Eclipse. So every time we make a change or say that dose is too high or we want some things, we're going back and forth, having a lot of plans in this process. What we do see, and this is also for the pelvic re-irradiation patients, that when we do this is the delta value of physical minus EQD2 corrected dose, that there are variations from minus 15 gray up to plus 12 grays. So if you do not do this, you could either get unwanted organ at risk dose or unwanted target compromises. So the trouble is not over yet, it has just started, because these patients, more often than not, they have been subjected to massive surgery. So the patient, this is from the primary scan or the primary treatment, and this is from the re-irradiation, where you can see the uterus is removed, the vagina is removed, the rectum is removed, the pelvic floor has been reconstructed with a muscular flap. So nothing is in place anymore. And we have issues. We cannot solve these issues within our system, so we still have to just look qualitatively on the plans. This is an example of, it's the same patient. We see the primary treatment. There are no high dose areas in the bowel volume. When in the re-irradiation situation, there are some bowel loops within the high dose. But we also see when we combine these treatments that when the bowel loops now in the re-irradiation, some doses in the very high dose area, this is probably not the truth because they weren't there in the beginning. So this is a higher estimate, and we cannot really, because there are some massive changes, we can't really overcome this. We have to look at the plans also to see, does it fit what we expect? Yeah, and this is actually just another patient, same surgery, where we can see that the high dose in the bladder was given posteriorly and inferiorly to the bladder, the re-irradiation in the top, but the high sum doses, because the bladder fell like posteriorly, inferiorly, is at the cranial end of the bladder, and that's not the truth. And just to show, sometimes they remove things, but sometimes the surgeons insert things, or they end up with large cysts. Here, a part of the sacrum is removed, replaced with a large cyst, and then the mesh that has just curled up in the corner on this patient. So added tissue can also be an issue. So these were some of the technical difficulties, which are both, I think, a bit different for proton therapy, but also important for photon re-irradiation. Moving on to some of the issues that are maybe more relevant to proton therapy. With the Bragg peak, with the steep dose gradient and the proton therapy being very sensitive to density changes, we have issues with movement that could be breathing, bladder movement, bowel movement. density changes, that could be gas or filling, and also anatomical changes. What this looks like is that this is a patient. Maybe you can see the tumor here on the left. It responded to radiotherapy during the treatment, and instead there is now a lot of air in the rectum. So what we planned is this dose to the bladder, and what we got during the treatment is this dose to the bladder. So that is the impact in not just the drawings, but in a real patient that was treated in the re-irradiation protocol. We also have issues with if the patient outline weight changes, gains, some accumulate fluid during treatment because of chemotherapy, that we get some target dosage problems. You can see just a little bit, that's actually no problem, but we can also see that with a patient with seroma that have major changes on a daily basis, we could not cover the profound part of the target with this change. And we also have issues with implants, with foreign surgical material. These different materials have different stopping powers that could affect the proton therapy. So we're very also aware of these matters. So what do we do to overcome or counteract all these uncertainties with proton therapy? We do a robust optimization, meaning that we recalculate the plan with the patient simulated in different positions and different range uncertainties. And then we look at the worst case coverage, target coverage. Would we still accept that? So that is a robust optimization for proton therapy, looking at these different these different scenarios, and we see, okay, we would accept even the worst case, so we would accept this target coverage, and we do the same for organs at risk. Furthermore, we use always more than one field, at least 3 fields to counteract these variations. We do the robust optimization with 14 different scenarios, and we also calculate in the bowel abdominal area dose with and without air cavities, and it looks a little bit like that up on the right, where you can see the dose is calculated with override of air and with air to see are we still okay with the organ at risk dose and the target coverage. And we also make our calculations changing the outline of the patient, ensuring that even though we have a bit of swelling, we still have target coverage. So we do that in the optimization process, and we measure on every implant of foreign surgical material that we irradiate near or within the patients. An example on then how robust is the treatment when we do all these things to counteract the uncertainties. This is again the re-irradiation patients who had 5 control scans during the treatment, and this is the ratio. You can see it's the planned dose. We give that throughout the treatment, and we can also see that in the control scans, the gray circles is always above the accepted worst case that we accepted in the beginning. So we deliver a very robust treatment. For the organs at risk, it's of course a little bit different because they're more variable. The most variable is the bladder, and we can see here that there are some ratios up to around 3 or 4, but when you see the large relative variations, it is with the patients with a very low dose, so it's still within acceptable doses. Okay, so the question was, does the superiority of physical properties with proton therapy beat the uncertainties? Well, there are some uncertainties that are related to re-irradiation that are not unique to proton therapy. Some might be a bit different. There are some uncertainties related to proton therapy, but they are not unique to re-irradiation. The only thing that is certain is the physical properties of proton therapy, that we give less integral dose. So my answer is still yes, but with more nuances. For many patients, proton therapy is a good option for re-irradiation.
So thank you for this excellent presentation. Are there any questions?
Thank you very much for the very nice presentation. I think at the beginning of your presentation, you mentioned that you have kind of a tumor board.
Yeah.
Like a national tumor board where you compare basically proton plans and photon plans for re-irradiation, and then you make a decision. And I wonder actually, how is this decision made and who does it? Because I think it's not black and white, right? And so who judges if a little bit more dose to the carotid artery is bad for the patient or not? So I think this is not an easy decision in many cases.
You're totally right. And this, it's the head and neck cancer study that do the comparative planning. And I talked to the PI for this project before I went and say, well, how far are you? Do you have any constraints? Do you have any criteria now? And he says, no, we're still at the level of discussing it. But this is a feasibility trial. And the hope is that using this time on the tumor boards, the national tumor boards will give some constraints or some criteria for inclusion into a continuous protocol, but it is the perceived benefit of the participants. Yeah.
So we are slightly over time, so I'll thank you for the presentation. I'll just...
Okay, so good afternoon, everybody. Yeah. Thanks a lot for this very wonderful meeting this afternoon.
Before the small gesture of meeting.
Of course, I don't want to. Okay, I have already the mic. So it's a big pleasure to introduce Professor Moshpetric. Yeah. So you are from USZ here. You are one of the experts in the world about brachytherapy, and I hope that we will learn about the differential use of brachytherapy in the field of irradiation. I guess that when some patients are underusing protons, I'm sure that many more patients are underusing brachytherapy. So I'm looking forward for your talk. Thanks.
Thank you very much for your kind introduction. I hope you don't think I'm crazy to start with the spread out brach feet with my presentation. I hope so. This is best. This is forward right now. I just have to make this. Can you help me? What's forward? What's backward? I pushed the wrong button. Okay, once again. Sorry for that. This is forward. Yeah, it's working. Okay, so it's really great that we have this amazing technology where the integral dose is reduced. We still apply margins in order to accommodate for the movement of the target, to accommodate for the setup uncertainties, and it would be nice, in fact, to have a technology where you could get even rid of that integral dose that we can see here, and reach even a higher dose within the target. And you can actually achieve this. You will be surprised there is a technology that can do that. So if you would insert the applicators inside, you will achieve a very low integral dose, a very high dose in the target, even with peaks in the middle, and you will get rid of the margins. As the target will move, as there will be setup uncertainties, your radiation will move with them, your beam will move with them. And if you add on top of that, that you get all these for a fraction of price, it's less than 1% per gray of the price. I made just rough calculation. I think it's really worthwhile considering it and keeping it in mind. And I think it's really great that I'm very grateful to be in a department which is very high-tech oriented in external beam, but nevertheless saw this importance of brachytherapy as well. As a disclosure, I actually do much more external beam than brachytherapy, but they always call me that guy who does the brachy. And it's always been like that, because we don't get many cases in brachytherapy nowhere in the world, but we should. And I hope I'll try to make a case for that.
You've seen getting rid of the margins. Is this important? We all know it is, but just let's look at the numbers. You see here, if you have a 33 cubic centimeters spheric volume and you add only 7 millimeters for ITV and for PTV, you end up with an 82 cubic centimeters volume that you need to treat with external beam. If you do it with brachy, if you're able to put the sources in, if it's accessible and if you have the technique and if you have the manual skills, you will treat a 33 cubic centimeter volume. So there's quite a difference, especially important for re-irradiation situation. And now I am at the beginning of my presentation. Actually, it was just slides I added this morning. And I have a long title, and I just shortened it to Needles Needed after this short introduction. I have no conflict of interest whenever I speak in front of radiotherapy audience that has main interest in external beam. I always add additional disclosure, where I say they have also no interest in conflict. What I'm showing here is, of course, a complementary thing. I'm not saying it's better, it's worse. It's a thing we need to. It's a technique we need to consider. My talk will be composed of 3 parts. 2 parts actually, brachy for irradiation for 2 clinical situations because we cannot cover all. And I took the topics that are maybe in my comfort zone, especially the gynae cancers. And then I will show some examples from our clinical practice where I will address the most important aspects that we need to take care of as brachytherapists doing the procedures. And we'll start with prostate cancer. This is in 2016 in Greece, Temple of Apollo in Delphi, where you can see here there's a group of brachytherapists sitting here this is a brachytherapy community having 38 questions and they need answers. They decide, let's go to the oracle of the Temple of Delphi. There sit 33 experts who will give us the answers. And in fact, the experts did say, let's answer those questions and let's give them the answers. And when we have 80% consensus, we will call it that this is our consensus answer. They managed to answer all 38, 17 were with consensus. And these are the answers. I'm just selecting some of them, just maybe the most important ones for us. Regarding the patient selection, this Delphi methodology study has shown, which was published in 2016, has shown that the experts found consensus on initial stage, which should be less than T3B, for re-irradiation, that the salvage stage should be also less than T3B to accept the patient for irradiation. 80% of experts or more had this idea, that the Gleason score initially should be less than 8, and IPSS was important, and of course M staging was needed, so exclude metastasis. They could not find any consensus, or they had less than 80% consensus on the topics. What's the initial PSA that is allowed? What is the PSA nadir? What is the PSA at salvage? And what is the PSA doubling time? There were many more, but I'm just mentioning maybe the most interesting ones. Regarding the treatment concept itself, more than 80% of experts thought that no ADT should be given during the brachytherapy salvage of prostate cancer recurrence after radiotherapy, and that HDR is a suitable method to achieve cure. There was no consensus. This is interesting, but you can see the numbers are quite high. There was no consensus officially on the dose that should be given. 71% although have voted to disregard past dose, to have a minimum interval of 2 years, was 77% vote, and 63% would give same dose as for the first brachy, while 73% would give even higher dose as for the primary treatment for the recurrence. These are the dose schedules, anything from 4 times 9, which is equivalent EQD2 of 108, down to 3 times 9.5, which is 90 gray in EQD2. These are the re-irradiation doses with brachytherapy, which you can achieve with brachytherapy. There were no consensus about the organs at risk constraints, and most people would treat the whole gland. And how does brachytherapy, so these are expert opinions, what to do, but how does brachytherapy compete with other therapies? There is a meta-analysis published in 2021 on this in European Urology, and the meta-analysis compared all local salvage therapies available. And here you can see the relapse-free survival forest plots, which are a little bit busy, so we will just look with a magnifying glass only into the adjusted proportions. And you can see LDR and HDR brachytherapy were the winners in this, let's say, competition between methodologies. The Surgery was in third place. We should mention that HIFU is very low, so we should not really discuss about this technique when talking about salvage, or even in the primary treatment for that matter. But there was quite a heterogeneity across modalities in these studies. These are mainly retrospective studies, study numbers, patient numbers, ages, ADT for salvage, whole gland versus not whole gland, PSA and nadir were quite different. So there's a lot of covariates that could affect these results. And when this analysis was done and adjusted to these covariates, including age, PSA, percentage ADT used, interval, whole gland versus non-whole gland, and type of study, where retrospective and prospective were separated. The investigators found the following. In green are good results, in red are unacceptable or disappointing results, and you can see again HIFU did not perform well. Surgery and cryo were good in terms of local control, but there were side effects. Whereas the radiation technique, including SBRT, LDR brachytherapy, and HDR brachytherapy, were sort of winners, with HDR being perhaps the weighted top, just looking at the numbers, but nothing statistically significant. Now I will go to my second part, which are the gynecological cancers and what is there in the literature about re-irradiation of gynecological cancers. Here I have to say this is a work we are still working on, looking at publications that, this is within our Jack Castro group, looking at publications that in the last century even published on re-irradiation. And there were first reports in the 50s, in the 60s, very interesting to read, but of course they don't bring much to our current knowledge. But if we look only at the last 20 years, from 30 years, from 92 to 22, we see that there were 35 original papers, mainly retrospective studies. There were 2, I think, 3 prospective, and these are the results. We looked only at reporting in this study. So how well these studies actually report things that we are interested in when we talk about re-irradiation. This is again very busy, so I just picked out a couple of them. Just look at the red ones. If you look at primary treatment, radiotherapy dose in the papers is reported only in 63%. And interval to re-irradiation only in 60%. And most strikingly, side effects are reported only in 3%. So you really cannot make out how damaged, how injured the patients were when they came from the first radiation schedule. And you can also see that the organ at risk dose at time of re-irradiation was reported in only 71% and the cumulative dose in 29%. Again, very importantly, quality of life only, 0%. None of the studies reported on the quality of life of re-irradiated patients in the last 30 years. Now, I would like to talk about the type of re-irradiation according to the consensus statement recently published. And as you mentioned with protons, Camilo, we also have similar experience in brachytherapy, although the studies did not report it's type 1. We see it's type 1. It's all central. It's all in the middle of the high dose field, what they reported on. And when we look at this is our picture for the gynecology purposes. It's not the lungs and the livers and stuff, but this is the gynecology central place. And if we look at this, you see, we need to talk about 2 types of type 1, actually. One is the, let's say, 1P, 1 peripheral, because it's in the area where the pulse dose is 45 to 60 gray, relatively low or moderate and homogeneous. And the central is the 1C, where you have pulse dose of 90 to exceeding 150 gray and steep gradients. Within millimeter, the dose will change for 10%. In such situation, in such an area of this steep dose gradient and high dose, of course, the dose summation issues, image registration issues become even more relevant and problematic. Nevertheless, if we look at the literature, this is also a recently published review by Sturza et al. From Vienna. Actually, this is an ABS, American Brachytherapy Society collaboration. And they published on the results of in the literature about these treatments with gynecological re-irradiation with brachy. And we can see that interstitial techniques are most often used. Sometimes intracavitary is added. High dose rate brachytherapy is most often used, much more than low dose rate with iodine seeds, for example. And there are several regimens. There is quite a heterogeneity. I don't want to go into numbers now, but it's anything from weekly to bi-daily schedules. The results after median follow-up, which is again very different from 1 to 5 years, lead to around 40 to 70% local control at 3 years, which is not at all discouraging. Overall survival of 50 to 70% at 3 years, and toxicity, this comes at a price at 15 to 30% of grade 3 or more. So if we ask ourselves now, you've seen this different expert opinions, different reporting habits, and also very different regimens published in the literature. Is there any science in this, or is this just art when we do gynecological re-radiation? There is no consensus at the moment on the interval from primary radiotherapy. We don't know anything about dose discount. Some people doing prostate brachytherapy will vote for losing 10% a year. There is no knowledge about chemo, but neoadjuvant chemo could be quite interesting to downsize before doing brachy. Spacers are very important. Planning aims and dose constraints are all unknown, and image registration and dose summation, especially for brachy. Currently, the Jack Kessler group does not, I will speak now for gynecological Jack Kessler group, does not recommend any type of complex dose summation strategies, such as rigid, non-rigid fusion with the dose summation, because there is just too many uncertainties. We just take the worst case scenario. And now I will come to our examples from clinical practice, where I will try to show some of the main concepts and on the techniques. This is a bit more relaxing after the numbers. When you have a high precision tool, you need to be accurate. Otherwise, you're hitting the wrong target, and that's very important. In brachytherapy, actually, there is nothing as accurate, as precise as brachytherapy in the field of radiation oncology. So precision here really matters, and steps that are involved where something can go wrong are so many that it really needs to be addressed with all earnestness. Here we will start with the case of a cervical cancer, stage 4 palliative case, first treatment with 39 gray in 15 fractions, 1 year interval, local progression. You can see, I hope maybe there's a small picture there of paravaginal big growth going into the pelvic sidewall, and external beam radiation therapy was given to downsize the tumor with 29 gray in 13 fractions, and then we added brachytherapy 3 times 7. And this example I will use to show the importance, and I will just highlight the importance of ultrasound guidance. You cannot do a good implant, especially such a relatively complicated thing, without an ultrasound guidance. I know finger is very important, and we always combine finger and ultrasound, but you cannot do it without one or another. And you can see that the result at the end is also very nice. This is the ultrasound. You can see the urethra in the upper part, and then you can see 1, 2, 3 needles added, and in the lowermost picture, it's already fully loaded. The whole tumor has been nicely implanted with needles, and the CT at the end shows it. And maybe just to say that the D2CC bladder in this case was accepted at 92 gray. D2CC for the rectum was accepted at 90 gray. This is the planned, this is the sum dose with previous treatment, and the urethral dose was relatively low. We achieved this, we accepted those constraints by giving the 60 gray to the target, which is quite a high dose. And the patient, after 5 months, had no residual PET active disease in this region. She had no new GI, GU toxicity. So this is something maybe to keep in mind. This is where we learn from. She had absolutely no symptoms from our treatment. Regrettably, she progressed first regionally, distantly, and then also locally in this region. For second case, endometrial cancer, 45 gray postoperatively, 5 years interval, vaginal recurrence, and then we retreated her with the external beam and BrachyBoost. And this case I will use to show the importance of mechanical displacement. You have seen here needles in the recurrence, but there is a mechanical displacer inserted into the vagina. And what did we achieve? No, into the rectum. The vagina was full of tumor. And you can see here the dose distribution, and anorectal D2CC in the sum was 99 gray EQD2 with previous treatment and re-radiation. But the spacer achieved that, the cylinder achieved that the opposite side of the rectum received only 20% of the dose. Next case, anal cancer, primary treatment, 45 gray, 6 months interval, progressive disease. The patient refused surgery, otherwise we wouldn't have treated him. And then we tried with re-radiation and BrachyBoost. It didn't go well. I will start with the with the outcome. It didn't go well. He practically did not respond well and remained with disease, and at the final stage progressed, was operated on, and is now doing okay with stoma. Now, this is the technique we used, and in this case, I would like to just show the comparison of VMAT and BrachyBoost. In this case, we did both plans, VMAT and Brachy plan, and we were able to compare it. And as you can see here, the volume that we treated with brachytherapy is much lower. The brachytherapy is here, and VMAT is here. And these are just the main dose volume parameters. Of course, there's a whole list of them, but you can see brachytherapy wins on all fronts. If we would have used VMAT, it would have come at a higher cost. So for the organs at risk and for the target, brachytherapy was a winner in this case. Next case, and now I'm heading to an end. Do I have another minute or not?
1 minute.
Minute? Okay. This is a soft tissue sarcoma patient where I would like to demonstrate the necessity of good pre-planning. This is a patient who had a recurrence of soft tissue sarcoma at the scrotal level, and you can see here a 3D reconstruction of the patient, and in fact a stereotactic plan of where to put the needles, what angles, what curvatures, what depth. It's a bit rudimentary. There is no template attached to this. We do it freehand, but it's very helpful in the clinical setting, because when you sit in the operating theater with such a drawing of the virtual patient and the femoral artery, which is near, and the bowel bag, which is also near, you would otherwise be in trouble if you didn't have such a nice pre-plan, which then helps you insert the needles. This patient had a hernia, and the bowel was down to the inguinal region. And we were able, you can see me here pushing with one hand the bowel away to be able to insert the needles. So we were able to reproduce, as you can see, the needle insertion in a reproducible way, in a Paris system, equidistant and parallel. I would like to mention another important parameter and then stop. This is the dose non-uniformity ratio. We always look at our plans very carefully, and the dose non-uniformity ratio is one thing that can reassure you that things might not go bad if you follow some rules. The dose non-uniformity ratio that we allow typically is less than 30%. And what does it mean? If this is the tumor, and we insert the needles, and here we have the dose distribution, you have V150, and then you have V100, and the ratio between V150 and V100 should be low. We allow less than 30%. If you would use only 2 needles, you would have a high V150 over V100, because you need to bring more dose from less sources. It's like an external beam, less beams, more hotspots. So the dose is invasive. The dose is the invasive part in radiation oncology, not the needles. And that's why brachytherapy actually should not be so feared and should not be said it's complex, it's dangerous because of the needles, but should be taken as a good option for our patients with recurrences. And now I would like to conclude that along with this slide, which I've shown in the beginning, you have the technology which is achieving these physical characteristics. It comes at the best price. It is not more complex than EBRT. We've seen MR Linacs, protons, so I don't think we need to discuss it. It's non-invasive. Needles are not invasive. The dose is invasive. It's really not invasive. It's the least invasive of all the techniques. It has the best dose conformity. We have shown it has good results. There are many unanswered questions, many uncertainties. And for the selected cases only, it's the best choice. And you need to have people with manual skills to do it. Thank you very much.
Thank you very much for keeping the awareness high for all the potential of brachytherapy. So we are a little bit late, but I hope that we can still take some few minutes for a discussion. Is this okay for the organizers? Good. So maybe there is a question from the audience. If not, I would like to ask you shortly about your strategy concerning a re-irradiation of prostate cancer, concerning the question whether to go towards focal or whole gland irradiation. You showed the results. Of course, those were all retrospective results, that there was not much difference between the standard focal approaches such as HIFU or cryo compared to whole gland irradiation approaches. What would you propose in case of a prospective study using HDR brachytherapy for re-irradiation after primary radiotherapy, either focal or a whole gland approach?
There's going to be a lot of guessing here because we don't know even for primary setting. But I would say if you have a case, there was one slide with picture there with the tumor on both sides, there's no question. But HIFU, for example, is a highly local therapy and it failed. Maybe it fails because it's so focal. Partial prostatectomy, for example, it also fails because it's so focal. I don't think that radiotherapy, even if it's partial gland, it's never focal. It also delivers, if you deliver 100 gray to this side of the gland, you will deliver 40 gray to the other side. For microscopic disease, that's quite enough. So maybe this is why the focal therapy could work. And these focal therapies differ quite a lot. Brachytherapy is quite something different than other techniques where therapy is truly focal. So I would personally go for whole gland in cases of bilaterality, in cases of multifocality, and maybe for a well-defined lesion on one side, probably just a focal radiation. And that's why probably there was also no consensus on the entirety of the gland in the expert group.
Okay, thank you. I think that could be a topic where we could or should find together in order to design a prospective trial. That would be very glad. Nice. Okay, maybe we are going towards the third speaker. Maybe I can take over. Is this okay? I introduce you, Solly Berister. I think I do not have to introduce you here in Switzerland. You're head of Department of Radiation Oncology in Aarau, and you are active in one of the pioneer clinics in the world to promote hypothermia. And of course, when we talk about re-irradiation, we have to include also the topic of hypothermia. So we are very much looking forward for your thoughts about that. Thanks.
Good, thank you very much for the introduction. So I think it's an extremely smart idea to give brachytherapy in case of re-irradiation, because it's much more conformal than external radiotherapy. But I'm convinced that to enhance radiotherapy, to really enhance the efficacy of radiotherapy by a potent radiosensitizer is also a smart idea. And this is the topic of my talk. Is heat the answer? So first of all, I would like to give you a definition of heat. So heat, how we use it in combination with radiotherapy, means heating the tumor to between 40 and 43 degrees Celsius for 1 hour. We combine it with radiotherapy or chemotherapy, and we aim for tumor selective sensitization. That heat is cancer treatment has long been known, but one of the first persons who really investigated it scientifically was actually William Coley. More than 100 years ago, he injected bacterial extracts into the veins of his cancer patients, and he observed the higher the fever he could induce, the more likely he could observe a response, a tumor response. So certainly today we have very sophisticated techniques to heat tumors. Here's a summary of some of these techniques. You can insert catheters or needles, also probes into the tumor and heat it from inside invasively. You can also read even ablative temperatures. You can heat tumors by ultrasound. You could do perfusion, which means you remove the blood out of the body, heat it, and then put it again in the body. So there are really multiple techniques. So the technique we are mostly interested in at Kantonsspital Aarau is radiative local regional hypothermia, which is basically done with microwaves. So you can see here a deep hypothermia device. So basically 4 antennas are put around the patients, and then they send out microwaves. These basically overlay in the tumor region, and then you get movement of loaded or charged particles, and this induces the heat. So there is no doubt that heat is a very potent radiosensitizer. This has been known for decades. So, for example, heat increases perfusion of the tumor, thereby reducing hypoxia. Heat inhibits DNA repair in the tumor, and heat also interferes with the cell cycle. Heat also interferes with the immune system, so it is known that it can activate dendritic cells or cytotoxic cells. So this is a completely a new field, and there's actually very little knowledge about heat interference with the immune system. But this is very interesting, I think, also for us. It has great potential. I think this is a very important slide. It shows the data of a meta-analysis performed with clinical studies investigating either radiotherapy alone or radiotherapy in combination with hypothermia. And basically, in this meta-analysis, it becomes clear that if you add hypothermia to radiotherapy, you get 20% or more improvement of complete response. And what we are talking about today is re-irradiation. And re-irradiation always is a patient who has a local problem. So he has a tumor that is regrowing in an area that's already irradiated, and we aim for local control, right? And with hypothermia, we achieve 20% more effect of our radiotherapy locally. And that's very important. But for sure, there are also randomized studies, even more recent randomized studies, showing that the combination of radiotherapy plus hypothermia can even improve overall survival. These are only 3 examples. One study was done in patients with advanced cervical cancer who could not get concurrent chemotherapy. So chemotherapy was replaced by hypothermia. And by adding hypothermia, there was a clear benefit of survival. The second study is in patients with sarcoma who get surgery, but also perioperative chemotherapy with or without hypothermia. And also in these patients, hypothermia improves overall survival. And the last example are patients with ovarian cancer and intraperitoneal metastasis. They get their chemotherapy heated, and then they get their HIPEC, and also in this case, adding heat improves even overall survival. So as you might know, Kantonsspital Aarau has been a pioneer in hypothermia in Switzerland over decades. This is a picture from 1988. Already at this time, deep hypothermia was performed at Kantonsspital Aarau. And in recent years, there was actually some important developments in hypothermia in Switzerland. I'm glad that Stefan Bodis is here, because he was the person who basically initiated 2 important steps. So the first step was that we founded a Swiss hypothermia tumor board, where all patients are actually discussed. And there's really a rigid assessment in this tumor board, and about 50% of the patients then are really referred to the centers for hypothermia. And the second step was that Stefan applied for reimbursement for hypothermia to the BAG, and he managed to get reimbursement for different indications. And actually, until 2 years ago, Kantonsspital Aarau was the only clinic in Switzerland with a deep hypothermia device. But this changed now. Within 2 years, we now have already 4 clinics with deep hypothermia devices and about 9 clinics, radiation clinics with superficial hypothermia devices. So I personally, as the representative of Kantonsspital Aarau, I very much welcome this development, because I think it will really enable us to work together and improve the evidence and do some clinical studies. So what is the rationale for hypothermia to combine with re-irradiation? I already said it. Re-irradiation dose is usually limited because of prior radiotherapy. Hypothermia is a potent radiosensitizer and increases the effect of radiotherapy by up to 10 gray. So if you think about it, basically improves radiotherapy by about 20 gray. So if you give re-irradiation with 50 gray, it should be then as effective as 60 gray. Hypothermia is known to induce only minor toxicity. And often we have patients who are referred for re-irradiation. So we would like to give radiotherapy with chemotherapy, but the patients have no systemic options left. And also in these cases, I think we have no radiosensitizing systemic therapy, so we can add hypothermia. So now I would like to show a few studies where hypothermia really was also investigated, specifically for re-irradiation. First study is a randomized study of hypothermia and radiotherapy for superficial and pre-irradiated tumors. This study was initiated by the group of Mark Dewhurst of Duke University. 122 patients were enrolled. 39 of these patients had prior radiotherapy. What I like about this study is before they included the patients, they first did a test hypothermia and really checked if due to the anatomy of the patient and so on, it was possible really to get a high quality hypothermia done. And only then the patient was enrolled and was then randomized to hypothermia or no hypothermia in combination with radiotherapy. And the result was that in patients who were treated with radiotherapy and hypothermia for their breast or chest wall recurrence, complete response rate was 66% and only 42% in the no hypothermia arm. Again, showing a 20% improvement in complete response. But what was very interesting, in the 39 patients who had prior radiotherapy, the gain was even higher, because in the patients who got only re-irradiation, only 23% had a complete response. But the patients who had re-irradiation plus hypothermia, they had a 68% complete response. And the reason for this is clearly that tumors that regrow in a pre-irradiated area are more radio resistant. They are growing in a hypoxic environment. And specifically in this biological situation, it's beneficial to add hypothermia. This is a study I like very much from our Dutch colleagues. So they investigated basically if temperature matters, not only to give hypothermia, but also if it's really important to give high quality hypothermia. So they analyzed retrospectively 112 patients. They treated also patients with mostly with chest wall recurrences and breast recurrences. They treated in recent years. So radiotherapy was given with either 46 gray, normally fractionated, or 32 gray in 4 gray fractions, together with 4 to 5 hypothermia sessions given weekly. And then they divided the patients into low quality hypothermia and high quality hypothermia, which was basically defined as a hypothermia parameter, which is the cumulative equivalent minutes at 43 degrees Celsius, which means how many minutes the tumor really had 43 degrees. That's just a surrogate for good hypothermia. And what you clearly can see is that if there is high quality hypothermia given, then there is also quite clear improvement in local regional control in comparison to if the local hypothermia is substandard. As I said, these are pre-irradiated patients. In these cases, our goal of our treatment is to achieve local control, and this was achieved here, but there was no benefit in overall survival. But importantly, also hypothermia did not add relevant high-grade toxicity. So another study, which actually was initiated or done in Switzerland by Markus Notter, is re-irradiation with water-filtered infrared hypothermia for recurrent breast cancer. On the left side, you see a very limited chest wall recurrence that we usually treat with microwave superficial hypothermia, but we also see patients that really have extensive recurrences shown on the right. And in these cases, we are somehow overwhelmed, and we think this is hardly possible to do any good to this patient with retreatment, but actually he did it. And he also co-developed a new hypothermia device, which is based on water-filtered infrared, which is shown here, which is very smart setup with thermography cameras installed on the ceiling, which have a high accuracy of measuring really non-invasively the temperature on the chest wall. And with this setup, you can also get a very controlled and not very labor-extensive hypothermia. And interestingly, he gave radiotherapy with only 5 × 4 gray, but he gave the 4 gray only once weekly. So you would say this is a ridiculous dose. I mean, in this pre-irradiated and large tumors, you would not expect anything as a radiation oncologist. But he combined it with hypothermia, and radiotherapy was always given basically really only minutes. So radiotherapy was given only minutes after the hypothermia, and he achieved very impressive responses. So he treated more than 100 or 170 patients, and he achieved complete or partial responses in 95% of these patients. And he even did a new classification system of the patients with very limited chest wall recurrence class 1 and extensive cancer cuirass class 4 patients. And you can see that in the early cases, or on the right side, you can see the local control, which was also very impressive in the advanced cases. And the nice aspect of this treatment is actually that you can repeat it. Also, it's already a re-irradiation, but the radiation dose is so low, only 5 × 4 gray given once a week without problems. You can repeat it a second time or a third time. Here's only one example of 2 patients on the left side, how the recurrence presented before treatment, and on the right side with the response. Then re-irradiation is also an important topic in pelvic tumors, as already shown by Primoz. This is a phase 2 study of radiochemotherapy plus hypothermia in rectal cancer, done by our colleagues in Erlangen. They investigated more than 100 patients, and of these 100 patients, 16 patients were treated for a local recurrence. So these patients already had their 50 grays before, and then a surgery, but then a recurrence in the pelvis, and they received again 45 gray plus 5-FU oxaliplatin plus hypothermia twice weekly. So the target delineation was very simple: the recurrent tumor plus 1 to 2 centimeters. And very interestingly, patients with pre-irradiated, with a recurrence with pre-irradiation had pathologically complete response in 38% of cases. So this is really very impressive. And also, if you look at the local, regional, or local recurrence-free survival at 1 year, it was also in the re-irradiation patients, it was 69%, and at 3 years, it was 49%. So that's, I think, good data. Also confirmed by a phase 2 study from Munich with 24 patients. Very similarly, rectal cancer pre-treated with 50 gray, then re-irradiated with 40 gray, plus chemotherapy, plus hypothermia twice weekly. And they achieved local progression-free survival, median local progression-free survival of 15 months, and a pain relief achieved in 70%. You can also do this in prostate cancer. Patients who had previously their 70 gray then have a local recurrence. In this study, all patients had large and symptomatic recurrences. They were treated with re-irradiation with a median dose of 40 gray, again with hypothermia, 8 applications twice weekly, and the median duration of complete or partial response was 12 months. And importantly, all patients achieved complete palliation of symptoms. So this study, I mean, you would say it's low patient numbers, but you all know it's basically impossible to do large randomized studies with patients for re-irradiation because it's very heterogeneous patient population. It's very individual treatment decision. And you could not tell the patients you will be randomized to radiotherapy alone or radiotherapy plus hypothermia. The patient will simply not accept it. There are even randomized studies applying interstitial and endocavitary hypothermia. And this might be interesting For Bremos, here is a table with even 5 randomized studies. Of these 5 studies, 2 studies applied interstitial hyperthermia and 3 studies endocavitary hyperthermia. So interstitial means usually combined with brachytherapy. And as you can see, primary endpoint was basically response. But in all of these in 4 of the 5 randomized studies, there was a significant improvement by hyperthermia. So, as I said, it's difficult to do prospective studies for these patients, but still there is one European project which is called Hyperthermia Enhanced Re-irradiation of Local Regional Recurrent Tumors, HETERERO study, which was initiated by our colleagues from Charité Berlin. And this will be a single-arm phase 2 study with 110 patients. It's basically a basket study with different entities. Treatment will be external beam radiotherapy plus hyperthermia, and the primary endpoint, local failure-free survival at 3 years. Unfortunately, it's not a randomized study, but as I said, I think this is basically impossible and probably not ethical. There's also breaking news. As I'm standing here, actually right now, there is a new deep hyperthermia device installed at Kantonsspital Aarau. This device will allow us more simultaneous temperature measurements, better focus control. We have a better patient positioning. It should also improve the comfort of the patient. And what is important, we also aim for integrated treatment planning, radiotherapy, and hyperthermia. Okay, so I come to my conclusion. Is heat the answer? Yes, I think heat is the answer for selected patients, because hyperthermia is still one of the most potent radiosensitizers. It has minor toxicity. It can compensate for missing concurrent systemic treatment options. And it is available in an increasing number of centers in Switzerland. Thank you very much for your attention.
Okay, thank you, Oliver. Magnificent. Are there any questions? Okay, there is one question. Okay, can you shout, please?
Yeah, yeah. There's actually different biological mechanisms underlying this radiosensitizing mechanism. They are not all experts. I think have the same opinion, but there are data showing that it's important that both treatments are close to each other. So if you give hyperthermia before radiotherapy, you clearly increase perfusion of the tumor and reduce hypoxia. But if you give hyperthermia after radiotherapy, you still actually have the perfusion effect, which still interferes with biology, but you also inhibit DNA damage. So it's not that clear, but it should be close to each other, as close as possible.
Okay.
And this is also why if we get patients referred to us from other centers, we usually give the hyperthermia and the radiotherapy at our center.
Okay. The chairman has just one question, but I will accept also one from Matthias.
Need systemic therapy. So how do you sequence with EBRT, hyperthermia, and systemic therapy, and in which kind of chemotherapy, IO, TKIs do we need to be cautious in terms of sequencing?
That's a very interesting question. Yeah, we have actually very little data about this. I mean, we have ongoing clinical studies investigating radiochemotherapy plus hyperthermia, for example, the HICAN study in rectal cancer, where we give 5-FU, mitomycin plus hyperthermia and so on. So with the new TKIs, there is hardly any data I'm aware of. And as I said, I think immunotherapy is extremely interesting. How could we integrate, you said it before, we have to integrate radiotherapy into systemic therapy concepts. And this is very interesting, what could be the role of hyperthermia there in the future.
Okay, so I will now close this session. I think that the conclusion. I let Nikki do the trick with the chocolates.
Thank you, Paula. Thank you, excellent, Oliver, for you as well. You may know those already, but enjoy them. Thank you very much for the talk. And of course, before I close this session, I have two other duties. I would like to thank for the first session all the chairs. And Paula, you're the first. Thank you very much for coming and for doing the chairing work. Ludwig, for you as well. And I fear that Frank already left. He's responsible for some faculty duties. But Daniel, here for you as well, for the chairs. More than welcome. And then I would like to ask Anja, you're not allowed to work right now. Thank you very much. Please come to the stage. Josipa, please come to the stage. I think you can organize all the meetings and you can do it perfectly and you can have a lot of visibility and you can push it on Twitter. But there are a lot of people behind that who help there and who help to keep everything together and with all the fancy ideas. So it's Josipa Kunadic and Anja Kühnes, who I would like to thank, who have done a tremendous job over the past few weeks, keeping everything together, organizing the email list, the website, the messaging on the social media channels, hosting the chairs, hosting the speakers. Thank you very much for this kind work. And this is... This is for you. Thank you very much. Anja, this is for you. And excellent. And now we have a break. You did a great job. You fared and lasted so long. We have a break till 4 o'clock. We will push you a couple of minutes earlier to come back. And thank you very much for joining. And now let's have some coffee and some talks.
So welcome back after the break. I just heard that there are not so many questions via chat, so please don't hesitate to ask as well questions via the chat.
Okay.
Now we switch to a very clinical session, tumor-specific, respectively site-specific re-irradiation. And I don't think I have to introduce our first speaker. It's Mahmoud Osain, and he will speak about head and neck cancer and irradiation. And most likely I pronounce your last name wrong.
No, it's okay. Thank you very much. Thank you. And how does it work, this thing?
Good question. I think maybe here, the next.
This is the next, and this is the previous. Okay, great. Thank you. So thank you very much for inviting me for this nice day of radiation. So I will try to make some kind of summary of what can we do as a radiation head and neck cancer. So my name is Osain. As you see, I'm coming from Lausanne, Centre Hospitalier Universitaire Vaudois. So the treatment of relapsed metastatic head and neck cancer, if you say, look what we do generally, if we have a local regional recurrence, the first question that we ask is the patient suitable for surgery? If it's yes, we will operate. If it's no, then we can ask the patient, is radiation possible with more than 60 gray or 60 gray and more? And about one-fifth of patients, let's say 20%, can be operable, and 4 out of 5, they are not operable. So if radiation possible, then we can start to think about radiation. If radiation is not possible, then we will, of course, directly go to the systemic therapy. And as you all know, the past standard of the systemic therapy for relapsed metastatic was the extreme regimen. But nowadays is the Pembro with or without chemotherapy after the publication of the Keynote 048. So The current diagram of relapsed metastatic head and neck cancer is if the patient is a CPS, of course, those who will, you do only systemic therapy in the beginning, so not suitable for surgery, no suitable for radiotherapy. CPS 0, extreme or TPEX. You will see, I will present the details on that. CPS more than 1, if it's between 1 and 20, and if there is no high tumor burden, then Pembro alone. If it's yes, then Pembro plus chemotherapy. If it's CPS more than 20, Pembro alone can be done. And if there are oligometastasis, things change, then you can put stereotactic radiotherapy, including with or without surgery. So let's go to our subject today. What we do in the local relapses in terms of previously irradiated patients. So as I told you, the treatment of choice is salvage surgery, and the systemic treatments are the Keynote 048, and the alternative standard of care is extreme or TPEX. And we should always ask the question, can we do re-irradiation if surgery is not possible? So there are different predictors of outcome when you do surgery. So let's say the survival depends if the initial stage is 4 or less than stage 4. If there are concurrent local and regional failure in the same time, which is worse than local or regional alone. And if you have 2 predictors, 1 predictor, 0 predictor, you see the curves. If you have 2, then the survival is nearly 0. So when you do surgery, you have, of course, complications related to the surgery, as you see in the slide. And when we look to the historical perspective in terms of systemic treatments, we have the classical Vaux regimen, as you see here, 6 cycles of this treatment in 11 weeks, which means 1 week treatment, 1 week no treatment, with hydroxyurea and 5-FU and 10 gray of radiotherapy once a week. So can we do full dose irradiation in head and neck cancer? Yes. There are large series in inoperable head and neck cancer. It's feasible, but increased with acceptable toxicity. There are limited volumes, and the curative potential, it depends. So we'll see. So let's look for the first re-irradiation in terms of palliative treatment. Excuse me. So what are the palliative treatments? I'm starting with chemotherapy. So as I told you before, the standard of care was extreme, and nowadays is the Keynote 048, which means the Pembro alone or Pembro combined with platinum chemotherapy. And there is also the TPEX study published with the Gortek group. It was published in Lancet Oncology, which is an inclusion of docetaxel, like the extreme, but extreme plus docetaxel with different dose levels. And this study showed that, which was a phase 3 randomized study, there was no difference between TPEX and extreme arms in terms of overall survival or other endpoints. However, we know that TPEX was less toxic than the extreme. So it can be considered if the patient cannot receive any immunotherapy because it's a CPS 0, other problems. So this is an example of the TPEX regimen, the patient with potential response after 1 cycle. So nowadays, what are the standards? There are 3 more studies that I want to present you before going to the radiation details. So the Keynote 048 late updated results showed that Pembro plus chemo is definitely better than the extreme. As you see here, the blue curve compared to the red curve in terms of overall survival. And the Pembro alone is better in patients with CPS more than 20. There is another study, the Checkmate 600-651. Here, the use of Ipi-Nivo was tested. There was no significant improvement compared to extreme study by using the Ipi-Nivo. However, the safety with Ipi-Nivo was much better than the extreme. And the last one, a study just published in Annals of Oncology, the Kestrel study published by Amanda Psiri. And here the durvalumab was used combined with tremelimumab or without tremelimumab, and it was not superior to extreme, but in patients who had let's say PD-L1 high PD-L1 expression, then the PFS was longer, and the patients who were experienced partial response had a longer response with using Durva and Trem. So it's suitable for patients who cannot receive the extreme regimen. So what about the palliative radiation? There is one randomized study published by the Gortek group. It's a relatively old study, published in 2011. They compared the Vox regimen versus radiation. They are compared to methotrexate, standard methotrexate in that time, 40 milligrams square meter per week, versus radiation plus chemotherapy. And there was no difference at all in terms of outcome. So as a palliative treatment, the radiation is not superior to systemic treatment if you think about the palliative situations. So if we look for curative intent, we have two types of curative intent, either definitive chemoradiotherapy, the patients that you cannot operate, or for those patients you can do surgery, can we do postoperative chemoradiotherapy or not? So let's look for a definitive chemoradiotherapy. It's possible. There are different series, the two RTOG studies, a study from Gustave Roussy and the Vox regimen from University of Chicago. They are definitely, this is with increased toxicity, with an acceptable 2-year overall survival around 20%. But as you see here, late toxicity is between 20 and 30% by doing definitive chemoradiotherapy. So what about postoperative chemoradiotherapy? Then we have again the Gortek study, the randomized trial of radiation, postoperative radiation after salvage surgery, which was published in JCO time ago, and it compared 60 gray postoperative radiation plus chemotherapy versus wait and see arm. And of course, the late grade 3-4 toxicity 2 years after randomization were much higher compared to the wait and see, around 40% compared to 10% of toxicity. What about the results? Doing a postoperative chemoradiotherapy after salvage surgery, does it help? Yes, in terms of local regional control, if you look to the blue arm and the yellow curve. But if you look for the overall survival, there is no difference at all. What about the IMRT when you do radiation? Nowadays, it's a standard, but we should discuss about it. There's a huge difference of volume of irradiation when you do an irradiation, even if your PTV is the same volume compared with 3D conformal and IMRT. And there are a couple of papers in the literature in terms of radiation showing that IMRT is much better than no IMRT. Of course, we don't question it nowadays, but we should show it when we do this discussion. And surgery before IMRT, it's better than not doing the surgery in patients where surgery can be done. So then another question, a radiobiological question is, hyperfractionation can be better than the standard fractionation. So there is a phase 2 randomized trial from Gortek. It's not a new one, published in 2018. The patients received either 3D radiotherapy or IMRT. Not all patients received IMRT. And they compared 60 gray in 5 weeks, 2 times 1.2 gray per fraction plus cetuximab versus the Vox regimen, 60 gray in 11 weeks, the standard historical Vox regimen. And as you see here, there was no difference, and there was no difference in terms of toxicity, neither between the two arms of study. However, A new study was published in the Lancet from China recently. This is not in all head and neck cancer, but it is in nasopharyngeal cancer. And they made a phase 3 trial comparing hyperfractionation versus standard fractionation. Here, this is not Vokes regimen. It is either 60 gray in 2 gray per fraction, 30 times 2, versus 64.8 gray in 1.2 gray per fraction twice a day. Chemotherapy was not obligatory. Some of the patients received chemotherapy, but IMRT was obligatory in both arms, and the hyperfractionated patients did much better in terms of overall survival or in terms of other outcomes than the standard fractionation. And as you see here, the grade 3 toxicity was around 60% in the standard fractionation compared to 34% in the hyperfractionated group. So stereotactic radiotherapy is also possible. There is a prospective study from Eric Lartigot from Lille by doing in some selected case, phase 2 study. As you see, it with acceptable toxicity and very not bad overall survival in terms of 1 year or 2 years. And there is another phase 2 study also prospectively done from Pittsburgh, as you see here the results, using Ray radiation and cetuximab using stereotactic radiotherapy. So what are the good indications of stereotactic radiotherapy according to the two published these two phase 2 randomized phase 2 prospective trials? So the recurrence should be more than 6 months time from the initial treatment, it's better. If it's a second cancer, not a relapse, it's better. If it's in the irradiated area, in general, it's better for stereotactic treatment. Of course, the patients should be inoperable because you should operate the patients first. And if the size is less than 6 centimeters, around 4 to 6, it's better than the others. So particle therapy already discussed this morning. So you can do better or not. The results are around the same when you compare to the SPRT or external radiotherapy radiation regimens. Maybe the particle therapy, let's say the carbon ions, could be maybe better because of the hypoxia reasons, etc. But of course, we don't have any evidence for that for the moment. This is a study by the Memorial Sloan Kettering, a multi-institutional report on the feasibility of outcomes for proton therapy for the Ray radiation. So what about brachytherapy? This morning we had also some brachytherapy discussion. So in CHUV, we did a number of patients with brachytherapy, especially before 2013, before Jean arrived in our department, because he's doing mostly the head and neck. He doesn't like brachytherapy, but I was doing in that time. And we were doing 48 grays in median 3 gray per fraction twice a day. And we did 44 patients retrospectively, analyzed it. We didn't publish it. With a median 23 months follow-up, we had a not bad local control, disease-free survival, and overall survival. In that time, our brachytherapy methodology was, when there is a patient who can be operated, then we were discussing with the surgeon, and the surgeon was putting the guides during the surgery, and then we were looking to the pathological report, and if there is a positive tumor less R1, for example, then we were doing some external radiotherapy and then brachytherapy boost. It was R2, then doing only brachytherapy, and if it's nothing, just taking the guides outside. Hyperthermia was presented by Oliver this morning, so I will not go into the detail, but it can be done for the retreatment, let's say re-irradiation of patients relapsed after first irradiation. You see different fractionation of radiotherapy they used in the study which coming from Netherlands, and then the results are not so bad. So what are my conclusions? the unresectable head and neck relapses in previously irradiated area, which means that the patients cannot be operated, are relatively common. And full dose radiation plus chemotherapy is feasible, and it is an alternative of palliative chemotherapy. It should be better than palliative chemotherapy theoretically, can be curative in selected cases. And in terms of SBRT, the stereotactic radiotherapy, I can say that it's feasible, it's fast, less than 2 weeks, few side effects, it's effective. And IMRT radiation is feasible. It's of course longer treatment, 6-7 weeks. Hyperfractionation seems to be better. I think personally that it is better, but in terms of evidence, it's only for nasopharynx for the moment. And it makes moderate toxicity, but bigger volumes are allowed, and it's effective. And for the systemic treatments, as I presented you before, the first line is the Keynote 048. Otherwise, the alternative standard care is Extreme, and TPEX is promising because it's less toxic than Extreme. And the second line treatments, of course, exist. So thank you very much for your attention.
Thank you very much. Perfectly in time. Are there any questions in the chat?
Yes, I guess. It's a good prognostic factor. I mean, not we should.
It's quite short, isn't it?
Sorry?
It's quite short. I would expect maybe 9 or 12 months. 6 months is close to kind of.
It's a little bit short, you say, right?
Yeah.
I agree with you. Yeah, but it's at least, I mean, you know, this evidence of radiation is not a huge, with thousands of numbers of patients. So, you know, Eric's paper is a small phase 2 study. He concluded like that, but, you know, I mean, I agree with you, but probably it depends if it's a young patient, a small relapse that you can treat with a very nice stereotactic irradiation. If it's not a thing of 5 centimeters of diameter, I think it would be okay. So it's case by case situation. Thank you. No more questions? Niklaus is coming with my chapter, right?
Thank you very much.
Thank you. Thank you very much. Thank you very much.
So thank you so much, Mahmoud, for this nice presentation. It's my pleasure to introduce the next speaker, Professor Dirk Daruscher. He's a full professor of radiation oncology at Maestro in the Netherlands. He's very well-known expert on lung tumors and the optimization of the treatment. He will discuss about the thoracic array radiation and the role of array radiation in the era of immunotherapy, minimally invasive surgery. Thank you so much.
Yeah, okay, it works. Okay, thank you very much for the invitation, of course. Actually, my wife was also very happy this morning that I was invited again in Switzerland, because she said, don't forget the chocolates, please. So don't forget me to recall that. But actually, it's really nice to be here, not only for the chocolates. Also because I received a very nice title of the presentation. Thank you for that. What is the role of radiation in the era of immune treatment and minimally invasive surgery? Thank you very much. Now we have to go to the next slide. Is this one? Yes. Fortunately, I have some conflicts of interest to show. And then, you know, this one was in the publication led by Nicolaus and Jonas. And actually, we have seen that before. I will more discuss this topic, not the other one. Because in reality, what we are facing in lung cancer, this is what I do for a living, that is that, is this the pointer? I hope so. doesn't work very well. But anyway, the real problem is actually that there's overlap. In reality, if you have an organ like the lung and you have like many patients with lung cancer, they have recurrent disease or new lung cancer. And quite a long time ago, we published a big series from the Dutch Cancer Registry showing that actually the lung cancer patients has a probability to have a new primary tumor at a rate of 2 to 4% per year. And the rate is the same between the 5th and the 8th year and between the 15th and the 18th year. So if you look at the likelihood that a patient will have some form of lung cancer if he survives one is very high. And that is really important to remember, because it means that if you look at so-called recurrent disease, sometimes it's recurrent disease, but quite often it's just a new primary cancer, even after a short interval. And therefore, nowadays, it is recommended, if it's possible, to really do an extensive genetic analysis. And not only look at, for instance, you have in both cases the same KRAS mutation, look at also other mutations, and you will see quite a number of patients have not a real recurrence, but they have a new primary tumor. And that is important, of course, because if they have a new primary tumor, you should approach those patients possibly in another way, because it's another curative treatment, and it's not because the tumor was necessarily resistant for the first treatment. So think about that as well. Now, if we look what is known before the age of the immune treatment, I will first discuss this, and then afterwards I will come to what is known in this situation of durvalumab, for instance, immune treatment. Now, in the pre-IO treatment, there was, as far as I know, only one prospective study looking at salvage SBRT, and that's a phase 2 trial led by people from MD Anderson. There's plenty of retrospective data, but we all know that most of the time retrospective data, we don't know very well which patients really came in, what was the process of selection before they came for radiation. And also the problem is also quite often that we lack very detailed information about toxicity. So therefore, I focus on this study where they screened 65 patients for the SABRE trial. That is already something very important. We have a recurrence, but it was only a recurrence which was amenable for SABRE. 63 patients were enrolled, and then after the end of the day, we had 59 patients which were amenable for this treatment. And this was the prior stage. So we have stage 1 in about half of the patients, stage 2 in 25, and then 22% had initially a stage 3 disease. So you see already there the selection in the previous stage as well. And then very interestingly, also related to the question of Matthias previously, the median interval between the prior non-small cell lung cancer diagnosis and recurrence was 13 months. And you have one patient with 2 months or so, but the majority has some years of disease-free interval, which makes sense, I think. You see, less than 4 years, 69, but 1/3 more than 4 years. And then you have a whole bunch of treatments before. The adverse events, because with SABRE alone, you hardly have side effects. You do have it, but it's generally not that big. But what you see here, that is grade 2 radiation pneumonitis, 24%, and grade 3, only a few as expected. But what is more interesting, and you see that on the right side, that is in the supplementary file of that publication, you see one of my favorites, that is that you also should take into consideration the baseline status of a patient, because you know that, for instance, in lung cancer, about 50% of the patients have some form of dyspnea before they start the radiation, not only because of the tumor, but also because of the smoking history. So assuming also, if you construct a dose relation between any type of radiation parameter and dyspnea, you should take into account how was the patient before the treatment was started. And then you see the baseline, grade 2, was about 8%, and after SABRE it was 14%, but reassuring that this grade 3 was already present in 8%, and after the treatment was 14%. So basically, it is an acceptable proportion of patients who have some grade 3, and this is only one maximum level of grade 3. So the majority of those patients, when you give them prednisone for a few weeks, and then you taper it off, most of the time they return to grade 2 or grade 1. So in general, the toxicity is as expected. But what is interesting here, that is they looked also in detail to the local control, regional control, distant control, and so on. And it's a pity that my pointer, I don't know how, because I don't think it, no, it doesn't work, sorry. But if you look at the local control, it's very high. That's the left upper curve, local control close to 90% or so, as expected with a classical SABRE approach. Regional control also pretty good, but then you see that the distant control is not that good, and the recurrence-free survival in the selected patient group, you see that still remains a problem. And you see that the survival probability on the right side after a longer period of time is actually not that good if you look also at the PFS, and that is mainly because of this metastasis. But still, I think in this patient group, it's worth to consider SABRE. Again, take into account that some of those patients may not have had really recurrent disease, they didn't look at it, but just a new primary tumor, which was amendable for SBRT. And they had also in their inclusion criteria no overlap with major vessels, no overlap with the main bronchi, with the esophagus, and so on. So when you only have overlap within an already irradiated lung, this is a very safe approach with pretty good results. Also in patients having received treatment for stage 3 lung cancer on beforehand. And that makes sense. I think that everybody would agree if you just have overlap in an already irradiated lung area, most of the time this is really, really very safe. And we accept all those patients for re-irradiation, except when patients have frank grade 3 ILD. This is a totally different situation, obviously. Then salvage proton therapy in the era before immune treatment. As far as I know, there's only retrospective data. Together with Holland PTC and Groningen, we also treat patients with re-irradiation with protons, but we don't have data yet. This is an American series, 65 patients. They receive 66 gray equivalents then in 2 gray fractions. A median follow-up of approximately 8 months, not that long. And again, what is interesting to see, disease stage, you see that stage 3A about 50%. Median interval between radiation course was about here 19 months, and the majority received concurrent chemotherapy. Salvage proton therapy, if you look at overall survival, progression-free survival, not that good. And the reason is actually, again, distant metastasis, because we all know lung cancer is, of course, a disease with a high likelihood to develop distant metastasis. On the left side, you see that any grade 3 toxicity or more was happening in about 40% of the patients, although, and you see also they had some constraints to the heart and the esophagus and so on. So is this working? Yes, this is working. Is this really better than re-irradiation with photons? You cannot draw conclusions. You can only say that this is feasible, whatever feasible may mean, of course, and that in some patients you do have a progression-free survival, which is a little bit longer, but look here, it's about 1 year or so. So can you do that? Yes. But I would only do that when you don't take risk for severe toxicity, because if you have, again, overlap with the central organs, then you may run in severe toxicity. And the question is, do you help the patient while doing so? Then, of course, we are now moving to the immunotreatment or the immune era, where many patients receive TKIs and immunotreatment, of course, and we don't have many data about that. What is the salvage proton therapy in the IO treatment. This is a small retrospective series of 22 patients. 2 of those patients, they had a recurrence after SBRT. 20 were included with the recurrence after concurrent chemoradiation, and only 10 of those patients, of those 22, had a recurrence after what I would call the standard of care stage 3 treatment, that is concurrent chemoradiation followed by durvalumab. So you see, this is really some case report. That's what we have at this moment. There was also a mix of recurrent and second primary tumors. Patients received 60 gray in 30 fractions in 50% of the cases, and some hypofractionation. And concurrent chemotherapy was delivered in 36% of the patients, most of the time carboplatinum, paclitaxel, a typical, I would say, North American regimen as well. No grade 4 or 5 toxicities, and 9%, so only 2 patients, had grade 3 toxicity, bronchial stenosis, and skin discoloration, and 5% grade 2 pneumonitis. So again, what can you conclude? Not too much here. And if you look here at the overall survival after 1 year, it was approximately, 68%. Local here survival, 1 year local control, 80%. But again, distant metastases remain a big problem in those patients. But again, small numbers, retrospective, of course. So what can we conclude? Can you do it? Yes. Do we have good data? No. We have some small series, except for SBRT. What about the dose constraints? What about repair? Actually, we don't know. I think that is fair to say. We are still in an era where I think there's a lot of ideas, and all of us would use something. But if you look at the real tough data, this is really lacking. Now, look at surgery. Is the situation better with surgery after radiation? And I'm not talking about surgery when you have delivered stereotactic radiation for a coin lesion, and afterwards you would do a salvage lobectomy. That's, of course, very easy to do. I'm talking really patients who received radiation to the mediastinum, radiation to the mediastinum, and then salvage surgery. This is a quite comprehensive review. Again, this is all retrospective. We are in the same line as with radiation. And what you see on the bottom line, that is that an R0 resection was achieved in 93% of the patients. But look to the whole range, what has been published in the literature, from 2008 to now, 200 patients. So you can directly imagine what a high selection bias there is, of course. So you can do it, of course you can do it. But that's frequently the case. And you can do it. That's like some people, they do major surgery with removal of half of the body, I would sometimes think. And can you do that? Yes. And then do it in 10 or 12 patients in a period of 21 years or something like that. So yes, but we don't know what the selection was, why this was done, and so on and so forth. And then the pathologic complete remission rate was 20%, because nearly in all those studies there was some form of neoadjuvant systemic treatment. So 20% had a complete pathological remission. And of course, if you have a quite good survival, that is because favorable prognostic factor, pathological complete remission, long interval, pathological complete remission, and then downstaging. What do you think? So again, surgery, you have some data in the pre-IO area, but it's not better than radiation. So don't let them fool you in a multidisciplinary round. If some surgeon says to me, well, I can operate a patient, and again, I'm not talking about a simple lobectomy, I say, well, take care. And there's a lot of complications. Well, I don't have time to discuss this, but a lot of complications, a lot of uncertainty, just like with radiation, basically. But it's not true that really surgery is so much better. We don't have the data. And it becomes even worse, because salvage surgery after concurrent chemoradiation and durvalumab, that's really only a few case reports. I really did my best to look at the literature. We don't have experience except for one patient or something like that, and I was quite glad to see also in the literature, in the published series, hardly. It's even worse than what I just showed you with the 22 patients with proton therapy, and 10 of them had concurrent followed by durvalumab. It's even worse in the surgical series. You find some case reports there, and maybe you will find another one because I missed one, I'm sure. But, you know, it's hardly nothing. So immune treatment, maybe you can give immune treatment after concurrent chemoradiation and durvalumab. I found one series, and that is retrospective, single institution. And it's very interesting to see that I saw the results of this study, which I will discuss now, popping up in a kind of unofficial guideline or something, a proposal. Yeah, it was really strange, Matthias, really. Because this is a retrospective single institution series, and those patients received classical concurrent to 66 degree, followed by at least one circle of durvalumab, and then they had refractory disease, and that was treated with pembrolizumab, 50 patients. Now, what are the results? You see 50 patients there. You see the characteristics here. Then the time to recurrence, it was approximately 50-50 within 12 months and after 12 months. And you see the number of durvalumab doses here. Okay, very nice. Overall survival, and I will look here, overall survival by smoking status and the progression-free survival by smoking status. You see current smokers as former smokers, so the overall majority of our patients. You see here the overall survival in this group, where you see the number of at risk, so very small, and about maybe 50% or so survive more than 1 year. That is what it is. If you look at the progression-free survival, it's really very bad. And the never smokers, of course, they have a very bad prognosis, which is logical. And what do you expect? Most of those patients have mutations which are related to resistance for PD-L1 inhibition anyway. But this is what they have done. And you look here, also the number at risk is very, very low. 10, 38, and then only 2 patients. And then you look here at what they looked at. KRAS mutation, PD-L1, and really nothing is significant, which makes sense, of course, because we are looking at a very small group of patients. And some of those patients also received pembro and chemo. Yes, 38% received pembro and chemotherapy, which is also quite strange because they showed already platinum resistant, and they gave again platinum plus paclitaxel most of the time. And even in this patient, because of this series, that's why I show it, because it's the only one where I showed you. It had some proponents I received it from different people who said you should really treat those patients with a recurrence with the combination of pembrolizumab and chemotherapy based on these results. So I was really, well, surprised, but it really is like we don't have anything better, so we should give it. It was really surprising. So my conclusions are that I don't have a conclusion, because based on the available data, there's many unknowns, there's no gold standard, there's really room for trials or at least prospective evaluation that we at least know, but when we do a prospective evaluation, what we should really do, that is that we start at the MDT, that we really know which patients come in, which type of induction treatment those patients had, and then which patients were referred to radiation, and what is the follow-up. That you can really have the whole tree of the patient, what really happened, and not only report retrospectively on all the patients who received already successfully a treatment. That would be very interesting with some data about that. And I know that, for instance, Astro ERTC has some programs or some ideas about that, but it's really important that we do something, because this is really actually to cry. That is my last slide. And if you ask me what do you do, it's something à la tête du client. Thank you.
Thank you so much for the very nice presentation. Any questions from the audience? Yeah.
What is a minimal gap before first irradiation and re-irradiation in thorax area?
The what?
The minimal gap. So I would...
Oh, yeah, the minimal gap. Well, actually, we don't know that. What I always try to do to obtain is to have pathology. I think that is really important, because in many of those patients, certainly in patients who have received chemoradiation followed by durvalumab, you are not sure that you are really looking at a recurrence. So that's my first take-home message. You should try to obtain pathology in order to prove that it's really recurrent. And when you have obtained pathology, what we do is we do just an LOH, just to see whether there's clonal it's the same tumor. And then when it's a new cancer, we try to do something in a curative way, if it's possible. And when there's when it's really a recurrence, then most of the time what we say, for something scary, we wait, we say 1 year, but it is really based on gut feeling. But of course, when you have a recurrence, and it's, sometimes you have a patient with a T3 and 2 disease, and you have one node in the lung, which is easy to treat with Saber, we give Saber, but that's very personal.
Dirk, I have a question, and I would like to have your advice on it. What do you do as a constraint in some of the lung constraints? For example, V5. When you do a re-radiation, do you accumulate the V5 or you just take the new one? I mean, you see what I mean?
I see totally what you mean. Actually, I don't care too much about the lung function. Because, no, really, because, and we published this 15 years ago, 20 years ago already, that it's not the lung function most of the time that's the problem. The problem is if you have a patient with IPF or not, and you see that not only on CT scans, but also the diffusion capacity. And when you have frank emphysema, and you have, that's basically no lung function at all, then most of the time you don't have any problem. That is also what Matthias many years ago published with Saber. So most of the time I don't care. And as far as I know, we don't know if you do re-irradiation, we all do it, but what are the constraints with which endpoints? Are we looking at radiation pneumonitis? Are we looking at lung function? What are we looking at? So most of the time I don't care too much about that, but what we really do is looking at IPF. Do we have signs that there's IPF, and is it IPF active or not? That is really something that you should look at also in primary setting, because you can really have patients who die fairly quickly after this, or after radiation or any type of treatment, actually. And I think for the future, what we should do is really look at genes which are related to resistance for treatment. And there are a lot of genes coming up, a lot of signatures coming up, and I think that would be ideal, because we need to know if you have a recurrence, is this because we are dealing with radio-resistant disease, or are we really dealing with just a lack of dose? That is something what I think would be very important to look at for future studies.
Thanks, Dirk. Short question. What do you do if your patient fails during the maintenance DURVA or shortly after? do you make a difference? So patient failing after 10 months of Durva or 1.5 years later, if Durva has already been finished. Do you adjust your treatment?
Well, actually, we don't know what to do with patients failing during or immediately after the failing of you. We all know that they are resistant for anything. So both for chemotherapy, for radiation, probably also for immune treatment. And what we see in that group, you see a preponderance of KEAP1 mutations as TK11 mutations and other mutations as well. But those are really popping up as a more mechanistic reason why those patients fail actually every standard of care treatment. So the question is, do we have something for those patients? And that's why it's so important to have initiatives like from Nikolaus and Jonas to look at new combinations or with new drugs. But I think that is really something where we should, well, actually, it's an open door, right? But this is an area where we should do at least prospective registrations, but really very well done, and trials, because otherwise we will have the same discussion in 10 years.
Great. Thank you so much for the very nice presentation. Thank you again.
It doesn't spare you buying your own chocolate for your wife. So very good. Thank you.
So let's move with the next speaker. So it's my pleasure to introduce Dr. David Pasquier. Unfortunately, is sick and he was unable to attend the meeting today, but hopefully we have the recorded presentation. So it will discuss about radiation for prostate cancer, discussing on the primary and the salvage setting. Is very active, is working in Lille, Centre Oscar Lambré. Is very active for SBRT, is very specialist, especially for radiation of GU tumors.
I want to apologize for not being able to be there with you today. On my side, I have to answer to this very interesting question about prostate cancer. First of all, I have to say that I can't make a yes or no answer. If I answer yes or no, I would be wrong. So it will be a sort of a gray answer between yes and no. I propose to you this plan. We will speak about the topography of intraprostatic disease after EBRT or brachy. Of course, MRI is very important in these patients. Do we have data in the guidelines about brachy and EBRT, SBRT? And we have to present a very nice work published in 2021. Do we have to treat the whole gland or just a part of the prostate? We will try to answer to this question too. I will make a focus on a few series and we will finish with a Delphi about SBRT and brachy. First of all, we have to keep in mind that prostate is the most common site of recurrence in all patients, even in patients treated with higher doses, as in this series published in 2015. This risk depends on the D'Amico group from 4 to 15% in this work. Interestingly, half of the patients with a clinical relapse presented with isolated disease in the prostate, only in prostate. Of course, prognosis of these patients is far better than that of patients with node or bone metastasis, with a specific mortality close to 20% at 8 years. So, prostate is the most common site of disease in all patients. As you know, a local salvage treatment is offered in a very small part of the patients. ADT is the most often used treatment in this setting. For example, in this series, observation was proposed in the half of the patient, but ADT in a second time in 1 in 2 patients. So at the end, more than 75% of the patients were treated with ADT surgery and brachy in only 2% of these patients. It's even worse in older series, in which more than 90% of the patients were treated with ADT and only 5 to 6% with local treatment such brachy and surgery. We know for a long time that most of these relapses occur at the same location than the first one. In these two large series of salvage surgery, more than 60% of the patients present with unifocal disease in the prostate. And so I think it's very important. A focal treatment could have been proposed in more than the half of these patients. So it could be a sort of signal in favor of a partial or focal SBRT or brachy in these patients. MRI is, of course, a cornerstone in these patients. Maybe, well, we are not sure of that. Diffusion could do better than DCA, but it's not very clear in all the papers, and both are important. We have now a sort of pilot for these patients named PIRR, with a score from 1 to 5, 1 to 5 for diffusion and for perfusion. And again, there is a link between the location of the first tumor, the recurrence, and the score. So PIRR is very important, and we have to use this. Yeah, it's a good news. We can draw a GTB on MRI after EBRT or after brachy. In this work, GTB dice was not so bad. In this paper, close to 0.6 in comparison, of course, with surgery, in comparison with specimen after surgery, after EBRT. Maybe PSMA PET could help in GTB definition, but data are scarce. I'm not very confident with this kind of data, and MRI is the most important is the city. Of course, a margin is applied in all studies of focal treatments to balance underestimation of the tumor with MRI. Can we find a brachy or SBRT in guidelines in this topic? Yes, with a low level of evidence for a brachy in NCCN, and it's very important for the first time this year in AAU. We can find brachy and SBRT, of course, with a word of caution. First, in NCCN, we can see that in patients in good condition, with a life expectancy more than 5 years, after biopsy, we can propose brachy, but with a low level of evidence to be. And here in EAU, for the first time again, brachy or SBRT, but in very selected patients and in a trial or in a cohort. So again, it's possible we could do that, but it's better to include these patients in a trial or in cohorts. Word of caution. I have to present, we have to discuss this very nice work published in 2021. It's, of course, a meta-analysis of all the salvage to treatment in these patients. Indeed, we have to say that level of evidence, again, is low to date. Whatever the salvage treatment, it's right for surgery and HIFU and so on. We have a few prospective series, only one about SBRT in 2021, 2 concerning LDR, and 4 concerning HDR brachy. These data are very, very important. I think it's a key point in this topic. Whatever the salvage treatment, RFS is around 50% at 5 years, with a few data concerning SBRT at 5 years. In this work, surgery was considered as a reference because it was, of course, the first solution in this setting. So all these treatment from a surgery to a brachy to SBRT allow to control the disease in half of the patients. No difference in all these treatments. Toxicity is, of course, again, a key point in these patients, and it's a good news too. We can see that all our treatments, LDR, HDR, SBRT, are far less toxic to the GU tract than surgery. again, in this work, surgery was considered as a reference. And we can see here that severe GU toxicity range from 5 to 10% in SBRT and brachy. So it's good news, and we can note to the very low rate of GI toxicity in our patients. Now, do we have to treat a part of the wall gland? Very, very difficult questions. And again, the level of evidence is low. In this meta-analysis, more than half of the patients were treated with a focal SBRT. The most used scheme was a fraction of 6 gray. And we can see that the severe toxicity was low, but with a short follow-up. Biochemical RFS, again, was 62%, but again, with a short follow-up in this series. Interestingly, we can see that in the first line, SBRT dose was associated with biochemical RFS and with severe GU and GI toxicity. In this line, we can see it's a good news maybe that a partial SBRT was associated with a lower toxicity, but not with a lower RFS. So again, maybe a signal in favor of partial or focal SBRT. Now we can make a focus on a few series. This series is the most important concerning brachy, including close to 100 patients. It was a phase 2 trial by NRG. Patients had to present a biopsy, of course, IPSS less than 15, PSA less than 10. It was a whole gland LDR brachy. Primary objective was late severe toxicity. Median interval between the two treatments, first one and salvage, was quite long, close to 85 months. And in this series, it's very interesting. The follow-up was long. Late severe toxicity was not so low, close to 14 patients in this series. Again, it's a whole gland brachy and not so low toxicity. Again, we can see that biochemical RFS, but here at 10 years, was close to 50%. So again, we can control the disease in half of our patients. Now, prospective series again of salvage SBRT, but I insist with a very specific technique by Fuller in San Diego, close to HDR brachy. Again, these patients had to present a recurrence, of course, after biopsies, more than 2 years after the first treatment, after EBRT or after brachy. No toxicity more than grade 1 before SBRT. We can see again that interval between the first treatment and this salvage SBRT was quite long. CTV and PTV were the same, so again, it's a specific technique. No margin from CTV to obtain a PTV. Biochemical RFS was 60% at 5 years, and late toxicity not so high, close to 17% concerning grade 2 and more. And again, it's GU toxicity. Very, very low rate, again, of GI toxicity in these patients. It's a good news, yeah. In France, we published with the team of Milan a series. It's not a prospective one. We included 100 patients. Again, same criteria for inclusion. More than 2 years after the first treatment, patients had to be assessed by MRI and PET. Again, a long time between the two treatments. Median PSA was low, close to 4. The most used scheme was a fraction of 6 gray in 2/3 of the patients. ADT was used in 1/3 of the patients. a partial SBRT was used in the half of the patients. Biochemical PFS was 55% at 3 years. And now in France, we have, after phase 1, we have now a phase 2 trial. It's an ongoing phase 2 trial using a six fraction of 6 gray. It's a partial SBRT. We can read here the main criteria of inclusion: positive biopsies more than 2 years after EBRT, not after brachy in this work. PSA less than 10. PSA DT, I think it's important to select this patient in PSA DT. No late toxicity more than grade 1. IPSS less than 12. And GTV is drawn on MRI. PET can be used too, but the most important, as we said, is MRI in this patient, and we apply a margin around the GTV from 5 to 7 millimeter to obtain a CTV. We have to include the sectors which contain positive biopsy, even if we don't see a GTV in these sectors. We just published the very early data, early results in the 21 first patients with a short follow-up. I'm not sure we can speak about late toxicity because this follow-up is close to 1 year, but late grade 2 GU toxicity was 41%, and we did not observe a grade 3. Now, to finish, we have a consensus concerning brachy and SBRT. Brachy first, 2 consensus concerning brachy. The first one in 2016, the last one a few weeks ago in Green Journal, both for brachy. So we can see that consensus was obtained in more than the half of the questions. Of course, we could propose brachy in patients with a life expectancy more than 5 years after positive biopsies, guided, of course, by MRI, but not only in the whole prostate, and I fully agree with that. 2 years after treatment, no late GU and or GI more than grade 2, IPSS score inferior to 16 or even 20. It was 15 in the last Delphi. Patients have to be assessed by MRI and PSMA PET, of course. PSA less than 20. It was 10 in 2016 Delphi. PSA DT superior to 6 months in previous Delphi. And no consensus, no choice on a focal or wall gland. Both could be correct. And no consensus on those two. Now, concerning SBRT, Delphi published in 2021. Again, a consensus was obtained in less than the half of these questions. Life expectancy more than 5 years. Of course, patients in good conditions. A previous ADT is okay, of course. IPSS should be now with more than half of the experts in favor of 15 as a threshold concerning IPSS. 2 years after the first treatment, okay. Patients have to be assessed by a PET, but of course PSMA is now better than choline PET. Interestingly, I think it's maybe the most important conclusion of this work. There is a consensus on a volume, and a GTV is defined on MRI plus a margin to obtain a CTV in this work concerning SBRT. No ADT concomitantly with SBRT. We can use Phoenix after this salvage SBRT. And the last one, I have to say, it's quite difficult to take into account the first dose when deciding the dose of a salvage SBRT. In my opinion, it's very difficult to take into account the first dose. It was not the same conclusion in Brekke-Delphi consensus. So, in conclusion, yes, we can propose a salvage Brekke or SBRT in this patient, but I think it's a key point in very well selected and informed patients. It's not fully a routine in my opinion. SBRT seems close to Brekke, but with a shorter follow-up to date. And very important, there are a lot of unanswered questions. Do we have to use ADT in this patient? We don't know. What are the optimal dose and volume? We don't know. It's we don't know for Brekke and for SBRT. What are the contrasts for OAR? We don't know. And of course, we need biomarkers more specific and more efficient than PSA and PSADT. So it's very important to continue to include these patients in the trials and in the cohort. Thank you for your attention.
So thank you very much, David. Unfortunately, he cannot hear and see us. He got also sick quite severely beginning this week, but I'm very grateful that he shared his presentation. So it was an excellent talk. We cannot have questions, unfortunately, but I already sent him a note and thanked him. And I would also like to thank the chairs, Catherine. Thank you very much. You may know those, but please enjoy it. Thomas, thank you. Very welcome. Thank you very much. And now it's my pleasure to chair together with Brigitta Baumert the next session, actually the last session, the clinical session. And I would like to introduce Joan van der Werden, a junior colleague from the Netherlands, and I'm very proud and happy that we have the next generation radiation oncologist that will soon replace us also in this session and give their experience and share their knowledge. Joan, I know actually quite well, only for a couple of years, but quite well from the Astro Palliative Radiotherapy course, and there together with Yvette van der Linden and Peter Hoskins and the remaining of the faculty, we developed the two ACROP Astro guidelines on palliative radiotherapy for bone metastasis. And Joan, you were one of the driving forces between the younger members, and it was a very nice pleasure to work with you. And now it's very nice to work again with you on reirradiation. So please go ahead.
Thank you very much for your introduction and also for your invitation. And I'm not planning on replacing you yet. It's a pleasure to talk about bone reirradiation. And I think the quote already gives away my answer, but I will show you why. And when I started thinking about reirradiation of bone metastases and looking at the other topics, I realized bone metastases are a little bit different from the rest of it, because safety is not much of an issue, I think. Even if you've treated your spinal metastasis, for example, with 10 times 3 gray, you still have plenty of room for those to be delivered to your spinal cord. Looking at this graph, for example, from the Quantec data. We have already seen, there's even some recovery of your spinal cord. So using the NIDER formula, you can even have a higher sum dose on your spinal cord. And there are even some expert radiation oncologists that dare to offer above 75 EQD2 dose on the spinal cord. And maybe they are acting too much like reckless cowboys. But if your medical oncologist is calling you and asking, can we re-irradiate this patient, your answer is probably yes. So if safety is not an issue, then the other issue is of course, is it effective? Miro Huisman and colleagues pooled the then available data on re-irradiation, and they saw that the pooled overall response rate was around 60%, which is very comparable to the primary setting. So yes, they showed that the re-irradiation of bone lesions is also effective. In fact, we do it quite a lot. In the UMC, where I'm from in Utrecht, 80% of our indications is for patients with bone metastases, and the re-irradiation rates I found in literature range between 11 and 42%. So around 100 to 500 patients a year are retreated in our department. So that's quite a group of patients. Because the median response to primary treatment is 3 to 4 weeks, you should not irradiate before 4 weeks after initial radiation. Most patients are retreated because of a painful recurrence after a median of almost 8 months. And a smaller number of patients have no response or have not a good enough response, and they are retreated. So what could be reasons for non-response? Well, maybe you didn't treat the right lesion in case of diffuse metastases, or maybe there's a shift during treatment because of setup errors, because these patients mostly have pain. And we saw the patients, that 50% of patients with spinal metastasis could have a shift in setup errors of more than 10 millimeter. I don't know if that's still a problem nowadays with more advanced techniques. And what is also interestingly is that we see more re-irradiation after 1x8 gray. So it's the re-irradiation rate there is around 20%. And after multiple fraction initially, the re-irradiation rate is around 8%. So gives multiple fractions a more durable response then? Well, I think the answer there is no. Because we see single and multiple fractions schedule are equally effective in pain relief. And investigators from the Dutch bone metastasis study looked in quite considerable detail to their re-irradiation data. And the results from those patients was that the median duration of response is after single fraction is 18 weeks, and after multiple fractions is 19 weeks. And a similar proportion of patients have pain recurrence. So they saw that patients were retreated more frequently at an earlier point in time and at a lower pain score than after single fraction than after multiple fractions. And in a multivariate analysis, they saw the primary tumor, the performance status, and also the randomization arm. They looked at 1x8 gray versus 20 gray in multiple fractions. Was predictive for getting retreated. And interestingly, another RCT, very old one, compared 1x4 gray with 1x8 gray, and they also saw that re-irradiation rates were quite higher after 1x4 gray than after 1x8 gray. So I think it's much more in the belief of the physician. The Dutch bone study was in 2000. And the single fraction treatment was then the new treatment, and they compared it with the old treatment. So maybe they didn't believe 8 gray was just enough. But I think just for the average patient, it can be enough. There are also 4 reviews now comparing conventional radiotherapy with stereotactic radiotherapy for painful bone metastases, and only one of them looked at re-irradiation. And they saw that re-irradiation was not higher after conventional radiotherapy compared to SBRT, but it was not reported in the RCTs. So we know it's safe, we know it's effective, and we also have information about what's the best schedule for retreatment. and Edward Chow and his colleagues actually performed the largest phase 3 trial in re-irradiation. And that's really commendable effort, I think. They did a non-inferiority trial with multiple international centers. And they recruited 850 patients, and they were randomly assigned to 1 × 8 gray or 20 gray in multiple fractions. And they really needed that much patients because only 60% was accessible at the primary endpoint, which was pain response at 2 months. They included slightly more men. Part of 25 of them had primary breast cancer, prostate cancer, or lung cancer. Most patients had a performance status of 70 to 80, so quite good clinical condition. Most lesions that were recruited in this trial were in the pelvic and hip pelvic area. And most patients initially got treated with single fraction radiotherapy. So in those days, it was, I think, a very representative patient population, except maybe that there were less spinal lesions that you would have expected. And these were all uncomplicated bone metastases. The maximum initial treatment was 30 gray in 10 fractions, except for spine and pelvic region, that was 20 gray in 5 fractions. These are the results from the intention to treat analysis. The difference between 8 gray and 20 gray was 4%, and the 95 confidence interval was 9.2, which did not exceed the non-inferiority margin of 10%. But you can also see in the per protocol analysis, then the response is slightly higher because they excluded the non-accessible patients. There, the risk difference is 6%, and confidence interval becomes larger, of course, because you lose power if you lose your patients, and that exceeded the pre-specified non-inferiority margin. So the per protocol analysis was not conclusive, but was also significantly less toxicity, of course, in the 1 × 8 gray. So they concluded that 1 × 8 gray is not inferior to multiple fraction in bone re-irradiation. And interestingly, also pain response was not associated with a response to previous radiation and with the previous fractionation schedule. So even if you had no response to the initial treatment, you have still a chance of response in your re-irradiation course. And also if you have had 20 gray or if you have multiple fractions, you still can have response. And knowing Edward Chow, I expected there were a lot of secondary analysis of this RCT, but because I was interested in are there more prediction factors, because maybe there are groups that need more radiation, but with respect to predictive factors, there's only one secondary analysis from his son, actually. And he found that gender or age did not differ. They're not predictive factors for response. So they still concluded that 1 × 8 gray is the preferred schedule for the entire patient population. I think there's a lot of unknowns here. I think we can do better in predicting which patients maybe needs more. And I will show you why in 3 patient cases. Because I really doubt 1 × 8 gray is always the best treatment for your patient. And this is a case of a 77 years old construction worker. Sorry, I didn't do that. He got diagnosed with prostate cancer in 2017, started with ADT, and in 2018 he had mild back pain, and there was a spinal lesion on the T10 and T11 level with no mechanical component, and because he was an oligometastatic patient having a lot of systemic options left, we treated him with 10 times 3 gray. And 10 months later, he came back because of clinical and radiological progression on the T10 level, and all the other lesions were stable. So looking at the Chow data, it is an uncomplicated bone metastasis. He should have fit in the inclusion criteria. You should have given him 1 times 8 gray maybe, but this is an aggressive tumor. No, let's start with the NOMS framework, because we use that to gather all the information and make a good treatment decision for him. And the NOMS framework was created by a group of orthopedic surgeons in the Memorial Sloan Kettering. And it's just a framework in which you can appreciate all the clinical data you have. So you look at the neurological status, the oncologic, mechanical status, and the systemic one. And in this case, this patient was neurological. He had no neurological complaints. He was previously radiated, and his tumor was shown to be radio-resistant. The spine was stable, we thought initially. And he also was in a very good clinical condition with a lot of treatment options left. So if you would have given him 1 times 8 gray, I think he would have failed locally, and it would have really been a problem because he had a longer expected survival. So we retreated him with stereotactic radiation 2 times 12 gray, and on our Planis MRI we saw that a vertebral was collapsed. So after that, he underwent a prophylactic fixation. And I looked up how he was doing now, and he's doing quite fine because only his PSA is now increasing with a doubling time of 10 months, but they're still waiting and see how it goes further. And locally, it's all stable and under control. This is a very recent patient of ours. She's an 83-year-old housewife. She had breast cancer in 1991, and this year she had a recurrence in her right breast, and she had several bone metastases. She had a painful lesion in her right clavicle, and we treated her with 1 times 8 gray. And then she came back because she was still in pain. She still had a good clinical condition. We saw some re-ossification, but not that much. And actually, this patient didn't fall in the Chow trial because she had a complicated bone metastasis. And maybe after a more fractionated radiation treatment, you see more re-ossification. So now we treated her with 10 times 3 gray. And the last one is a 76-year-old physiotherapist. He had a renal cell carcinoma in 2011. And in 2016, he got several metastases in lymph nodes and several bones were affected. And we treated him with 1 times 8 gray on the painful lesion in 2016 on the L3 level, and also the left iliac bone in 1 treatment field. And I started my residency in August 2016, so this was my second patient. I didn't know better at the time. He was also started on systemic treatment with a good clinical response. In 2011, he came back to our department because now he had a lesion on L4, which was not really painful, a little bit, and the spine was stable. So we again used the NOMS framework. I already gave it away a little bit. No neurological complaints. Otherwise, very good response on the pazopanib, mechanical spine, and after this there were also systemic options, and the oncologist was intended to continue the pazopanib. So in this case, we also irradiated the stereotactic treatment, and I looked him also up. In January, he had his last PET scan, which was a complete metabolic response. So re-irradiation with SBRT, can we do that? Well, actually, the spine SBRT was designed for re-irradiation. The first report of Hamilton in 1995, he treated 5 patients for re-irradiation. But there's otherwise not much data about it. There's a systematic review of 9 cohort studies, and they found reasonable high local control rates, also reasonable high pain control, which is higher than reported in the CHOW trial and also higher than reported in the systematic review on the conventional radiotherapy. They saw a vertebral compression fracture rate of 12%, and only 1 patient developed radiation myelopathy. And this one was not included in the review because it was published a little bit later. But this is the largest multi-institutional pooled analysis on spinal re-SBRT. They included almost 250 tumors. They were retreated after almost 14 months on average. The cumulative dose to the tumor was around 868, and the max to the spinal cord was around 60, but the range was very high, as you can see. And they also saw that the results were quite good. So 1-year local control was 83%. 3/4 of the patients reported a clinical improvement in pain with low toxicity rates. If you want to know what is the safe dose for SBRT, please look up the SAGO high-tech recommendations. And if you want to know how you should contour the TKL-SEC, there's a guideline for that. Because you should make you have to know how to contour the TKL-SEC, otherwise your constraints doesn't make sense. I already see that I should end my presentation. And what we did not discuss, there's a lot more to talk about. We did not discuss secondary irradiation, which is an increasing scenario that is increasing in this area of new systemic treatments. We did not discuss other organs at risk, including the bone itself. We did not discuss challenging in defining your organ at risk volumes. There's also pseudo-progression after SBRT, so you should be aware of that and not immediately retreat. There are strategies to avoid repeat irradiation, maybe by SBRT, or maybe by decreasing the initial dose, because 1 × 6 Gray is as effective as 1 × 8 Gray, and then you can repeat it 4 times. But that's one for the coffee break. So to conclude, there's much room for re-irradiation. Response rates after re-irradiation are around 50%, so there's also room for improvement. And there are promising results after re-irradiation with SBRT, but we need randomized data to confirm superiority. And please use the NOMS framework to make up a treatment plan that is for your patient specific. Thank you very much.
Thank you very much, Joanna, for this quite critical overview. We have room for a quick question. Dirk, please.
Well, I recall when at the late 1980s, when the study in UK was done with 1 × 8 Gray and subsequently 1 × 4 versus 1 × 8, it was without any type of imaging, even diagnostic imaging. So there was quite a number of patients. I'm sure we had some geographical misses, but still what was striking, that is 60% more or less with 1 × 8 Gray pain reduction, and with 1 × 4 Gray about health. But when you had even with 1 × 4 Gray pain reduction, the time in response was the same as with 1 × 8 Gray. So my question to you is, how does radiation works in the palliative setting of pain killing?
Oh, that's a difficult one. Well, we don't know the exact mechanism. And some patients respond to radiotherapy within days. So I think there is just, some kind of stopping of the cytokine release. And sometimes patients have to wait much longer than the 4 weeks. So maybe in those cases the pressure on the bone capsule is less. But actually we don't know exactly. And also the mechanisms for re-irradiation are really unknown. And it is striking that some patients do not respond to the initial treatment and they do respond to the second treatment. So actually we don't know.
So basically, shouldn't we have more insight in biology also in order to influence this kind of treatment as well?
Yes, yes, I completely agree.
I think that was a clear statement, Johan. Thank you very much again for the statement that we should not consider non-response regarding to pain to not perform re-irradiation. So I really liked this statement. It was very important for the palliative setting. Thank you very much.
Oh, thank you.
Chocolates for your spot. Thank you, Johan, for joining us.
Thank you.
Thank you. I'm happy to announce now Mariangela Masecci from the University Cattolica del Sacro Cuore Milano. Yes, you will bring some experience and research from abdominal re-irradiation. You're going to show us. Please go for it. Thank you.
Okay. Good afternoon, and thanks for inviting me. I received this hard task of accompanying you in the sea of abdominal radiation, where we are navigating poorly explored waters and, let me say, troubled water. And these are bullet points, my relation. I think that before setting sail, we need to define where do we want to go. So how we want to go high with the re-irradiation dose. And we have to look up in the sky and see if there are no black clouds coming to be sure that we will not harm our patient. And we have to know which complications may cause to our patients. And we have some idea of what is the radiation damage mechanism to the organs at risk and to what extent they recover. And after this whole reasoning, maybe we can have some suggestion. This is to look for an answer to the first question. If we want to have a minimal chance of controlling a recurrent tumor in the abdominopelvic region, which dose should we deliver? Well, there are some evidences from retrospective series, as usual when we talk about re-irradiation, that doses lower than those administered in the first course of re-irradiation, as this case below 40 Gray, has very low chance of providing long-term tumor controls. In this retrospective series, for example, only 3 patients had tumor control after 2 years, and they were colorectal tumors. Again, this is another studies from the group of Professor Valentini, who is my mentor in Rome, who found that after 40 days, rectal tumors, about 1 out of 5 patients has a chance of having the tumor controlled. But maybe if surgery is not planned in the treatment of our patient, we have to go higher. In these other studies, retrospective studies again, others show that patients with rectal cancer who received more than 50 Gray had better local control than patients who received less than 50 Gray. Pancreatic cancer is a complete different story, probably. Indeed, here you can see in this study of re-irradiation in recurrent pancreatic cancer using stereotactic radiotherapy and hypofractionated regimen, even if dose is comparable to the first course was given, the overall response rate was remarkably inferior to that of the previous irradiation, and no patient had a local control after 1 year. In this other trial, we can say that some patients received doses higher than 60 gray. Of course, these are retrospective data, so we can ask only the suggestion because of selection bias of patient, of course. But we can see here that some patients may experience long-term survival in pancreatic recurrent cancer. We don't know if the dose matters, but we have some suggestion that we should go higher with the dose in pancreatic cancer. And is it safe? Is it safe to deliver such a dose in the radiation of abdominal tumor? This is the question we tried to answer a few years ago with a group of colleagues of the Italian Association of the Radiation Oncology. And we decided to perform a systematic review, and we included only studies reporting the outcomes of toxicity of radiation. And as you can see, radiation doses ranges between 20 up to 90 gray, and cumulative dose were extremely various. What we have is that the pool rate of toxicity was not negligible, around 12% of patients in this meta-analysis, and the rate of toxicity did not change after omitting studies where doses higher, cumulative doses higher than 100 gray has been delivered, and toxicity rate seems not to be affected by the fractionation schedule used. Of course, this kind of analysis had a lot of limitation. First of all, the inclusion of studies with very large heterogeneity in terms of patients, tumor sites, so that maybe the patient selection has a larger impact than treatment-related factors on the risk of toxicity. For example, in these studies that was included in the meta-analysis, others report around 1/3 of patients who develop radiation-induced liver disease, and the only risk factor they found was the pre-existing liver function, while the dose to the liver was had not significance. And this is another study that I show you to underline another challenge that we have when trying to gathering data from retrospective studies of radiation, that not all the toxicity are due to radiation-induced damage, but only a portion of toxicity, and a lot of events that are reported as toxicity are actually due to tumor progression. But trying to answer this question in order to inform the patients that we have to deal, that we have to treat, which severe complication may radiation cause. Let's focus on a more selected patient group. In this case, I show you a sum table reporting outcomes of studies where radiation has been performed for recurrent pancreatic cancer. Here you can see studies are quite homogeneous in terms of previous previous dose and radiation dose, and technique that has been used, and also the volume that has been treated. In all this study, the treatment volume was only the gross tumor volume with a very tight, very small margin. Well, in these studies, the number of patients having severe effect was very low, below 10%, And two main types of side effects were reported. The one type is due to a break in the wall of the bowel, such as gastrointestinal bleeding, ulcer, or perforation or fistula. And another type of complication is due to reduction of the lumen of the bowel, such as obstruction or stenosis. What I would like to underline is that some severe events occur very early after re-irradiation. For example, one patient had gastric fistula 1 month after re-irradiation, and another patient had duodenal stenosis 1 month, only 1 month after re-irradiation. This is a little bit surprising to me, because I used to think that obstruction is a late complication, so that fistula is a late complication. But who are particularly at risk of having complication after re-irradiation? Again, only retrospective data and only some suggestion. For example, in this study, author observed that those patients who had toxicity was those ones who had received very high previous dose, and those ones who were retreated after less than 4 months after previous irradiation. In these other studies was observed that patients who had toxicity was those with a pre-existing duodenal injury, pre-existing duodenal damage, and those who received very high cumulative dose to the intestine. And this empirical observation, let me say, fits perfectly to what we know based on pathologic study in animals. This is a study in Macacus rhesus that were irradiated, and the bowel was examined after different time points and after different level of doses. And what was observed is that the mucosal damage, the extent of the severity of the mucosal damage increased with the increased dose, and the recovery is lower as the dose is increased. And in some cases, there could be no complete recovery of the mucosa even after 6 months from irradiation. And we know that late damage is due to both damage to the mucosa and the submucosa, and the severity of the late damage is greater is the dose, and also is more progressive as the radiation dose is greater. Well, coming back to the question, I was really excited when I found this publication, and I really was very happy, because I say, yes, I found the answer to my question, because others saw to calculate and accumulate dose distribution to the organs at risk and correlate this accumulated dose distribution to the severe adverse effects, thus determining possible dose constraints. My enthusiasm was again reinforced by the fact that they used the formable registration to calculate the accumulated dose to the bowel, and started to fade it down when I reading further, and I see that they did not perform what they intended to do, because they had very few events of severe toxicity, so they changed the outcome, and they include only G2 events, including, for example, nausea and vomiting. And they observed finally that maybe the risk of toxicity can be related to the dose, to lower dose, to the stomach, or the intestinal dose, to the mean dose to the intestine. So I think that there is much more work to do to find an answer to our question. Furthermore, one of the main challenges we have to face with is that, as you know, the bowel moves, so the planned dose is not really could be not actually identical to the delivered dose. Let me say it's very different sometimes. This is, for example, a case that we treated. This is the first simulation. You can see in the yellow line the portion of duodenum that is contoured within the 2 centimeter from the PTV. Here is the simulation, and the other 5 figures represent the duodenum in the other 5, the fraction of treatment. So the planned dose can be very different as respect to the actually delivered dose. Well, but what we can say based on the data we have, we can say that if we use very conformal technique, we limit as much as possible the intestine, maybe and we give those peripheral dose ranges between 30 to 50 gray. We can be quite sure that our treatment is safe. In this studies, different plan objectives were used, but most of them followed international guidelines, such as the AAPM report. And in the study by Agivara, a constraint of cumulative dose has been proposed. So coming to the conclusion, what is the minimum effective irradiation dose? Of course, there is no universal truth. There is no one-size-fits-all answer. But based on retrospective data, maybe at least 40 gray, we have to give at least 40 gray, and possibly we have to go higher with the dose if we want to have a minimal chance of controlling the tumor. And it is safe in most patients, but it can be really unsafe in some patients, particularly those with a pre-existing, recovered, or organs at risk damage in the radiation field. And the main danger is to cause an ulcer in the gastrointestinal tract, which may proceed to a perforation or a fistula or an obstruction. And we know that we should take into account the previous dose that has been delivered in the first treatment, and we should take also into account the time that has passed since the previous irradiation, because the recovery can be incomplete, both in the mucosa and in the submucosa. So what dose constraint can we safely recommend? Of course, bowel motion can determine large discrepancies between the planned and the delivered dose. So future studies that aim to define those volume constraints for the bowel should deal with this issue. Meanwhile, based on current knowledge, the risk of severe toxicity is probably less than 10% if we stick to the dose constraints and a sufficient amount of time has passed since the previous irradiation and the patient has no previous story of ulcer and received not too higher dose in the first irradiation, and we try to keep the dose to the bowel as low as possible. Thanks for your attention.
Hi, Angela, thank you very much for this talk, this detailed talk. I think, in the sake of the time, I would like to discuss, we can discuss with you afterwards. We'd like to continue with the next speaker. Thank you.
Mariangela, thank you very much. And thank you very much for your cautious word about the gastrointestinal tract. Very important to me. Thank you very much.
Thanks a lot. So I'm happy to announce Jonas Hillman. He will present now some interactive cases we can discuss together, and I would like to get you all engaged to discuss these cases shortly. Thank you.
Yeah, so thank you, everyone. I have the honor to give the last talk with a case discussion on re-radiation. I'm not quite sure if I should be happy to be closing this session or if it's rather a burden, because most people will probably be either hungry or have fallen asleep. So this is why we want to keep it a bit interactive and have your smartphones out so that you can scan the QR code that will pop up later on and participate actively. Also for the people at home following us, of course, because I think it's more than 200 people still listening or sleeping in front of the computer. So this doesn't work. Yeah, it does. Okay, so I will present a case that was treated as at the University Hospital of Zurich. We have a male patient, 69 years old, who presented, first of all, in an excellent general condition, had no relevant comorbidities, but in early 2018, he presented with a facial nerve palsy. A biopsy was taken, and that revealed a poorly differentiated salivary gland carcinoma of the parotid gland. He unfortunately was initially oligometastatic with lung and bone metastases, and then underwent a number of treatments before showing up for the first time here at the University Hospital Zurich. So he was operated, he underwent a neck dissection, he underwent multiple lines of systemic therapy, so initially was treated with chemotherapy, then underwent antibody-drug conjugates, hormonal therapy, and anti-HER2 therapy based on molecular markers of that tumor that were analyzed. He also, even before showing up at USZ, underwent multiple courses of radiotherapy to the primary, to painful bone metastases, and most importantly, to multiple lung metastases that were treated with CyberKnife SBRT, as well as to mediastinal lymph node metastases. I'm holding it the wrong way around, okay. So this was then the first presentation at the University Hospital Zurich. The patient presented with repeat oligoprogression. He had 3 new lung metastases, and 2 of those were in the immediate proximity of the previous irradiation of the hilum and mediastinal area. That was treated 10 months ago with a total dose of 55 gray in 20 fractions. The last radiotherapy was very well tolerated. He had no severe acute toxicity and, very importantly, also no persistent late toxicities. At that time, he was under systemic therapy with anti-HER2 therapy. So there were a couple of challenges in this situation. The patient was, of course, multidisciplinarily evaluated, as should be done in these situations. From a radiation oncology perspective, the challenge is that there were high cumulative maximum doses in the area of the proximal bronchial tree that we would accept. And this is, of course, an issue because this is a serial organ, as you know. From a systemic perspective, the patient had somewhat limited therapeutic options. As you know, he already received quite a few lines of systemic therapy, and otherwise the current line was very well tolerated. He was also surgically evaluated by our thoracic surgeons, but surgery was not considered an option and also refused by the patient. So we then planned re-radiation for this case. We prescribed the dose of 40 gray in 8 fractions, prescribed to the 65% isodose line, and assessed the cumulative doses here to the proximal bronchial tree, which you see here in the DVH and also on the images below. And you see, we had quite high maximum doses on the proximal bronchial tree, here with a maximum dose of 160 gray. But on assessing this anatomically, we saw that these maximum doses were really point maximums more in the peripheral parts of the proximal bronchial tree. And if you can see that the dose distribution, the areas more centrally located received significantly lower doses. So, of course, there was a relevant risk of toxicity, mostly of stenosis or bleeding, but this was discussed with the patient and accepted. And now I would like to ask you, so take your smartphones out, you can scan the QR code, or you can go to menti.com, type in that number, and tell us what you would do. So it's all anonymous. There are no right or wrong answers. You're not going to get chocolate for answering, but we would like to see what you would actually do in your clinical practice. We'll give you a couple of minutes or like a couple of seconds, maybe not minutes. Otherwise, we'll never get out to answer this. Okay, so answers keep coming. I think, yeah, the majority of you would go for a hypofractionated SBRT treatment. There are some who would also do palliative radiotherapy, and hyperfractionation would also be done by some. There are also some people in the room who wouldn't do any radiotherapy. Maybe that's medical oncologists in the room. But what do we base our decision on? So we are, of course, in a situation where we do have limited data. The table that we see here was a summary by Robert Rulak et al., who conducted a consensus on thoracic re-irradiation and presented some suggested dose constraints. But it's important to bear in mind here that these are mostly based on expert consensus, which is based on a limited number of mostly retrospective data. And we see here that the maximum dose for the proximal bronchial that they're recommending is somewhat around a Dmax of 100 gray or maybe a bit higher. There are different reports on central thoracic re-irradiation. We also published our experience from Zurich with a cohort of 42 patients that were treated for local recurrences for metastases. In this cohort, it was very well tolerated. We only had one death that was most likely not related to radiotherapy toxicity. Most of these patients were also receiving doses to the proximal bronchial lower than 100 gray. However, there was one case that received a dose of 187 gray, maximum dose to the proximal bronchial, who also tolerated this well without any toxicity. So as you see, data are limited. Severe toxicities may occur, and individualized decision-making is therefore really key when discussing these types of treatments. We then go to the next presentation at our center for this case. So this was 6 months later. The patient again presents with lung metastases. So it's again a repeat oligoprogression. Until that time, he's been treated for more than 10 metastases in the lung. Everything was well tolerated, no late toxicity. Clinically, he had an adequate lung function. We didn't perform any dedicated testing of the lung function at that time. And he had switched the therapy and got to the anti-HER2 therapy, a chemotherapy agent now. Again, what are the challenges in this situation? So now it's the cumulative mean doses that are most important to us. We don't expect really an overlap so much of the high dose volumes, but it's a cumulative dose to the lung that is important for us. Again, the limited systemic option remain an issue, but overall the patient still has a low tumor burden, and therefore we wanted to go for an ablative treatment there. This is the plan that we created. So the dose that was prescribed here for re-irradiation was 35 gray in 5 fractions. And if you look here at the cumulative doses to the lung, those are actually pretty high. So we have a D mean of 25 gray, a D 20% of 40 gray, and a D 40% of 20 gray. So there definitely is a relevant risk of pneumonitis, for example. The central lung structures were not affected in that time. So now the question again is, if you would go for treatment here, and what would you do? What type of treatment would you deliver to this patient, if any?
Yeah. Any complaints from
he didn't have any complaints. No, he didn't have any symptom. He was completely asymptomatic in a good performance status. Okay, so that's quite clear. We have 38 responses here. I think that's a clear game. Okay, so hypofractionation is the winner here. What do we know or what do we don't know about re-irradiation of the lung? Again, this is a table that I'm showing from the consensus paper by Robert Rulak and colleagues, who compared these different constraints or non-existence constraints for the lung. The authors couldn't agree on a constraint for lung re-irradiation and suggested that it should be based on an individual cases. And this is really because there's so little that we know actually about recovery of the lung tissue and what could actually be safe dose constraints, as we also saw in the question that was asked to Dirk here after his talk. There's some data, though, that might help us when guiding these individualized decision-making. So we have this report here by Kelly and colleagues from MD Anderson, who reported data on lung re-irradiation with SBRT. And interestingly, what they saw is that the rate of grade 3 pneumonitis was higher, significantly higher, for out-of-field relapse compared to in-field relapse. So it's of course not quite clear what is the reason behind it, but you can think that it's maybe related to the underlying biology of the lung and of the underlying pathology of how radiation pneumonitis works. So you can think that the area of the lung that's been irradiated is fibroticized in some way, and therefore may be less susceptible to developing a new pneumonitis in case you retreat the same area. Moving on, the patient 4 months later presented with a brain metastasis, or he had a brain metastasis before. He had a brain metastasis actually before, which was treated with radiotherapy, but then recurred. And this is the scenario we have here. So after previous SRS have a recurrence of the metastasis, it was then resected. And we are now 1.5 years after this previous SRS of the brain metastases. Currently, the patient was doing well. He didn't have any acute toxicities after the last radiotherapy in the brain. He didn't have any late persistent toxicity, but he also didn't have any symptoms from that brain metastasis that was now operated on. So the challenges are here, again, new systemic therapy lines has just been started in this situation. So he now went to an anti-hormonal therapy based on androgen receptor expression of the tumor that was found. Otherwise, systemic disease was well controlled and he had a low tumor burden. But in this scenario, we would have very high cumulative maximum doses in the brain. However, some word of caution, of course, he has been partially resected in that area that was irradiated. So what we did, you can see it here. The dose that was prescribed for irradiation was 30 gray in 10 fractions, and a large volume receives actually doses more than 120 gray. And we see that the maximum doses here are really even more than 160 gray. However, if you look closely at the images, you see that much of this area that's receiving very high maximum doses is actually in the resection cavity. So it's really, again, here important to acknowledge also the limitations that we have from dose accumulation, and that we really have to look at the anatomy in detail. So, of course, there is a significant risk of CNS necrosis, but the patient still decided then to go for the treatment. I would now like to ask you what you would do. So we have a high overlap with the previously irradiated region, but the metastasis has been resected. We have a high cumulative Dmax expected, and yeah, the affected organ is, of course, the brain. Okay. So we have more than 30 people answering. Most would offer fractionated radiotherapy. On the second place is no wait and scan, and some would deliver single fraction radiosurgery. So let's have a look at the data. So we know that some recovery, or that recovery takes place in the brain. Actually, it's probably together with the spinal cord, the area where we have the best evidence of some recovery taking place. We have here data from a review that was actually done about re-radiation for glioblastoma. And we see that above 100 gray, the risk of toxicity with necrosis obviously is increasing. And really in this area where we are here, we likely have a really significant risk actually of toxicity. Then should we do it? Should we deliver adjuvant radiotherapy, adjuvant re-radiation here in this scenario? Very recently, we have this report also from MD Anderson published that looked at the post-operative management of brain metastases that were recurrent after previous radiotherapy and were then afterwards resected. And what they found is actually that the high local failure rates of 40%, if there's viable tumor in the resection specimen, probably does mandate an active approach, meaning adjuvant re-irradiation in selected patients at least. So to conclude, the current status of the patient is that he's 5 years after diagnosis. He has had 1 surgery, yet by now 6 lines of systemic therapy based on different molecular markers that were found. He has had more than 10 courses of radiotherapy for metastatic and locally recurrent disease. And he's actually coming here next week for his next follow-up schedule with PET-CT and MRI. He's also doing very well. He doesn't have any impairment of his quality of life, no severe late toxicities. And this is, of course, just one positive case example. But what it does show is that re-irradiation and repeat irradiation can actually be powerful partners for patients in combination with precision medicine. However, and this is the word to conclude, as you heard before, there are still many unknowns in re-irradiation, and therefore collaborative research efforts are needed. And just while we were sitting here a few minutes ago, we actually got a notice from EOTC that the prospective RECARE study, which will include patients treated with high-dose re-irradiation, is open from today. So the first center, the General Hospital in Vienna, has now officially been opened. So we are very happy to start accruing patients there. And to go back to the metaphor in the title, I here have an image which I unfortunately didn't paint myself, but AI DALL-E helped me doing that, to create an image in the style of German artist Gerhard Richter of a ship sailing in uncharted waters, but with some light of hope on the horizon. And this is hopefully the work that we are doing here on re-irradiation. So thank you very much for your attention.
Thank you very much for this very, very nice ending of this symposium with a case, of course, where we selected something that we felt special, that worked out quite nicely. But by seeing the answers from the questions, we realized maybe it's done more frequently than we thought before. Excellent presentation, Jonas. Again, thank you very much. Also for you, the chocolate, and I consider this a really nice coincidence that the RECARE cohort is now open. So let's start improving patients there and really generating the prospective evidence. Thank you very much, Jonas.
Thank you.
And of course, Brigitte, for sharing with me the chocolates for you as well. Thank you very much. Now, it's 6:10. And of course, we are over time by 10 minutes. And I would like to apologize for that, but I'm not doing it because I really, really enjoyed this meeting. And I think 10 minutes are worth over time for a meeting like this. And normally it's much more difficult to keep the time scale of such a condensed meeting. So thank you very much to the audience, to all of you, to the online audience, which still kept online with us till now. So thank you very much for joining. Thank you very much for really engaging in this re-irradiation endeavor. I also would like to thank all the speakers for preparing their talks, for giving their talks, for standing up for question and answers. Of course, all the chairs for coming here and helping making this symposium really, really a nice success. And with this, I wish you farewell, a nice evening. And thank you very much.